Good morning, everybody. We're going to go ahead and get started. We've got a full day. So welcome to the Special Committee on the Federal 340B Drug Program. We are going to start off this morning. Well, we all know each other. We've got some different staff than what we that are kind of new to us. So maybe we'll just introduce the middle table. Randy, why don't you start?
Scott Abbott, Reviser of Statutes Office.
Megan Leopold, Legislative Research.
Leanne Thone, Legislative Research.
And Melissa Rennick with Legislative Research.
All right, thank you. So we're going to turn the table over to Megan Leopold, the fiscal analyst with KLRD, who's been head staff on this for this committee. So take it away, Megan.
Thank you, Madam Chair. I'm just going to briefly remind the committee of the direction. This committee was directed in the Omnibus Appropriations Bill, and the Legislative Coordinating Council affirmed and appointed the members. The directive of the committee is to review the 340B drug pricing program with the objective of gaining a better understanding of how the program is implemented in Kansas and the experience of the participating entities. I also wanted to call your attention to a resource page that's been created for the committee. The resources can be found on the Kansas Legislative Research website. That's ks.gov. If you click on the committee tab, you'll find the 340B committee. Click on that, and there will be a resource link at the top. Lastly, I just wanted to call attention, along with the testimony from today's conferees, the Kansas Insurance Department has also submitted some written testimony, which is in the packet that's included in your folder.
Okay, thank you, Megan. So to kick things off, well, I'll just let you know that one of the first things I did with the appointment of this committee was to reach out to NCSL for some of their subject matter expertise. And they made some recommendations for some speakers and sent some material on like what other states have done, and we'll have that available for you to see. But this recommendation of our next speaker, Lisa Scholes, has been one of the speakers for NCSL, and she's got a pretty good size bio. So I'm going to read the first paragraph, and then Lisa, I'll let you fill in anything that that I'm missing that you want to share with us. So Lisa Scholes is head of industry relations, joined Century Data Systems, a compliance technology company, after 3 years as COO and senior vice president at 340B Health. During her tenure, she grew the association's membership, guided strategy, and helped influence legislative decisions to affect program change and ensure 340B had a trusted pharmacist voice. And so we will be hearing from Ms. Schultz on WebEx. Is she on? She's not on yet. Representative Barker.
I know we're missing a member or two. Are they on WebEx? Who's on WebEx?
I believe Senator Hildebrand is on WebEx. Who else are we missing?
Water. Sean Tarwater. Representative Tarwater.
And Senator O'Shea is on WebEx, as well as Representative Tarwater.
Okay,
So,
thank you. I just want to make sure who's present.
thank you. All members are in attendance for the committee. Okay. Lisa, I just read an introduction for you. Are you there? Senator Pittman. I almost called you representative, sorry.
That's okay, Ms. Chair, Madam Chair. While we're waiting for the speaker to get on here, is there a directive that we need to be focused on for this committee at the end of this process, other than our overall awareness and digging into this? Do we have to produce a report of some sort at the end of the day or at the end of 2 days?
At the end of 2 days, I believe we'll submit a report. Yeah, but today is, I kind of planned today around overall awareness, education this morning, and then how it impacts Kansas, and then we'll hear this afternoon after lunch from the different stakeholders. I'm not seeing her yet. Senator Gossage.
Yes, just a few moments ago, we were told that there was a document, and I'm online. Where is it that I can find that?
I think you need to go to I'll let Megan respond.
Oh, that's what this is? Okay.
If you go to the Kansas Legislative Research website, are you there? At the top, there's a tab that says Committee. And if you scroll down, I believe it's under the heading Special Committees, 340B. And then at the top of that page, there should be a link that says Resources or Resource Page.
Okay, I'm on testimony. So would it fall under testimony? Or is
No,
there a different
it should-
resource?
Are you on the KS
Oh.
or the KLRD?
I'm on the Kansas Legislative
Okay,
website.
it's a separate website.
Okay, that's why. All right.
But from the homepage of the LI, on the left side, there should be a link to Kansas Legislative Research. And you can click on that and then,
Thank you.
Do we have Lisa yet?
You guys hear me?
Yes, we can hear you now. I read an introduction for you. I just read the first paragraph. If there's anything else you'd like to share, please feel free to do so about yourself, and welcome to committee.
Thank you so much. Yeah, I'll save for, when I give my presentation, we'll kind of go through a little bit more introductions, but thank you. So whenever you guys are ready, you just let me know and I'll share my slides.
Yeah, we're ready right now.
Excellent. Okay. Can you see my slides? Just to check.
Yes, we can.
Excellent. All right. Well, good morning, everybody. And thank you so much for the invitation to speak to the Kansas Legislature. And thank you to Megan for giving me the opportunity to share some 340B kind of facts, some overviews, and really dig into the stakeholders to get some perspective around the 340B program. So by way of introduction, thank you so much for the intros, but what we're going to cover today is just a brief overview of 340B. As I mentioned, talk to the stakeholders. We're going to talk a little bit more about the 340B prescription flow, how that process works. And then I'm going to talk on some industry updates that will be important as you make decisions and have a little bit further discussion. And then I'll leave time for Q&A towards the end. So a little bit about my 340B journey. I am a pharmacist. I also like to tell folks I am a 340B evangelist. If you've ever heard of such a thing, well, you've got her in front of you. My background in 340B started actually out in the retail side, and I worked in a health system, a large hospital in Texas, where I really learned, or as I like to tell people, cut my teeth on 340B and really understood what the program was about and how it helped the community. From there, I went to work for HRSA, so the Health Resources and Services Administration that actually administers the 340B program. I worked for them as a government contractor and ran their call center, which was all of the folks that had questions about how the program operated went through their call center. I then moved to work for an association. As everyone knows, in Washington, D.C., there are associations for everything, and there is an association for 340B. I was there for 3 years as their chief operating officer and chief pharmacy officer. And now I'm at a healthcare technology company where we actually do a lot of the back-end work for administering the 340B day-to-day for both hospitals as well as community health centers. And we'll dig a little bit more into what those types of what we'll call covered entities are. So, an overview of 340B. My job today is to give you what I'll call the 5 W's and the H. So you're going to learn the who, what, when, where, why, how. And I'm not going to dig into the weeds. We're going to stay at the 50,000-foot view. And this is really to give you a foundation for much of what your discussion will probably be like today as you hear from different stakeholders. So we're going to talk about the program itself and what its intent was, where the name originated from. I get a lot of people that always ask me, oh, is that a 304B, kind of like a 401k? Nope. We'll dig down into that. And then we're going to talk about when it was put into place, who the participants are, and then what are the benefits. And again, we're not going to spend a whole lot of time on this, but I think it's essential to really understand that the 340B program is a federal drug discount program, and it requires that manufacturers provide discounts on outpatient drugs only. And the discounts typically range from about 25 to 50% below what we'll call AWP, the actual wholesale price. So that would be like if you went to buy a car at MSRP, basically the price would be reduced by anywhere from 25 to 50%. And it's voluntary, so to speak, if the manufacturer is going to participate in either Medicaid or Medicare, they are then required to participate in 340B. So a lot of folks really want to know, well, what was the true intent of 340B? Why was it created? And what you'll see here is an excerpt from the House when they passed the 340B law, which was in the Public Health Service Act, PHS. So you'll sometimes hear 340B called PHS. You'll hear it called 340B, or you'll hear the Public Health Service. So those are some acronyms that you might hear thrown around. But the real intent was to help stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So a lot of folks figure, okay, so this was put into play to really help the hospitals and the clinics so that they could utilize those federal resources to treat more people, and again, more eligible people. So where does this name come from? So it was originally in the Veterans Health Care Act. It was passed in 1992. Again, you'll hear it called the Public Health Services Act. And it's Section 340B. So pretty fancy there, but it's administered through the Health and Human Services, HHS, through their group called HRSA, as I mentioned earlier, the Health Resources and Services Administration. And it's also underneath several other what we'll call bureaus, the Health Systems Bureau, and you drill it down, and the office that actually runs the 340B program is called the Office of Pharmacy Affairs, often termed OPA. Who is participating? So when you look at it, there really are 6 key stakeholders that really determine how the program is administered, which is through HRSA and their Office of Pharmacy Affairs. Those that benefit from it are the covered entities, and we're going to talk again about who those covered entities are. But the manufacturers participate by providing that discount, and it's provided through what we'll call a wholesale distributor or a wholesaler. There are different terms for those that actually get the drugs to the covered entity. And then Medicaid is also impacted by the 340B program. And then you'll hear the term contract pharmacy or a contracted pharmacy, which again, those are contracts with retail, independent, grocery chain pharmacies with the covered entity to ensure that drugs can get to their eligible patients. So when we look at the different types of covered entities, you'll often hear hospitals as one of the main utilizers of the 340B program, but there are also what we'll call grantees. And this is a list of all of the grantees that are eligible to participate in the 340B program. So you'll see community health centers listed as federally qualified health centers or lookalikes, and an array of different types of other clinics or services that also participate in 340B outside of the 6 current eligible hospital types. Then last is, why? Why is this program around? What are the benefits? And it starts with the covered entity. So that 340B eligible covered entity is to help them stretch those federal resources, reach more patients, and again, provide more comprehensive services. And all of those things benefit the patients that they see as well as the community that they serve. And it really allows for access to affordable medications. There are discounts provided. There are free drugs provided to their patient population. And lo and behold, it improves clinical outcomes because they have access to other services that 340B allows them to do. Things like providing mammographies, locations that they may not have otherwise, or other costly services that hospitals provide that are not covered usually completely by different government programs that are essential to the community. So let's dig into the stakeholders. So, I mentioned 6 main stakeholders, but really there is something called a 340B marketplace. And you will see in this diagram, the covered entity is center. It is always centered to all of these conversations because 340B evolves around that covered entity's ability to participate in the program. And then you'll see along, the outer part of the honeycomb are a lot of other stakeholders that have a role to play in supporting the covered entity. As far as they interact with the program, although they may not necessarily be written into the 340B program as part of the law that covered entities have to do. But when we dig down deeper, it's much more to the 340B community. This is one of my favorite pictures because, again, it shows the covered entity is center, but then there are a lot of different stakeholders that influence how the covered entity is able to participate in the program. On the far left in the yellow, what you'll see is called the 340B Coalition. And this is a group of associations that support all of those various 340B covered entities that we talked about earlier. These are their associations that often have a voice in supporting the 340B covered entities. But you also have what I'll call PhRMA, which is PhRMA, the actual association, BIO, the association that also has a voice. And then, as I mentioned, the government plays a huge role in how 340B is administered. Now that it's at the HHS, the federal level, but also at the state level, because as you heard me mention earlier, Medicaid plays a big role in how 340B is utilized at the state level. And so you'll see at the bottom in red, all of the different federal agencies that have some influence on 340B. HRSA being number 1, followed by CMS because of the Medicaid connection at the federal level. But then you have a lot of those grantees that we mentioned earlier are all administered through some of these different federal organizations. Then we talk about the federal government contractors. So there are different groups that support HRSA in administering the program day to day. And those are organizations that have a government contract with HRSA, and that's the American Pharmacists Association. It's the Prime Vendor Program, which you will hear termed APEXIS, that provides a lot of the education and the technical support around the day-to-day operations of 340B. And then there's a group called the Bazell Group. And the Bazell Group's function is to work on audit and compliance in collaboration with HRSA. And that's to make sure that the program has oversight continuously in collaboration with HRSA's Office of Pharmacy Affairs. Then manufacturers, I kind of put them close to the covered entity because this program cannot operate without manufacturer participation. Manufacturers are integral. They are the ones that provide the direct discount upfront to the covered entity based on their eligibility to participate in the program. And then, like I said, there are a lot of influencers in the 340B community, and those are in the green box. And that's where you'll see the wholesalers, the contracted pharmacies. You have 340B and non-340B technology companies that play a role, as well as many other types of what I'll call vendors or consultants that support some of the day-to-day operations for both the pharmaceutical industry as well as the covered entities. And you have think tank associations that do studies and research in the 340B program, and there are several law firms and advocacy organizations, which I will call non-associations, so they're not in these coalitions, but also weigh in and provide insight into the 340B program. So it is a large community of stakeholders. But again, the 340B covered entities are what is center. So some of these other influencers that you may engage with in some of your discussions as you talk to your constituents about the 340B program, these are some of the names that may pop up in your discussions. And they are either affiliated with manufacturers, or they could be affiliated with covered entities and helping them administer the day-to-day program. But they all have various viewpoints on how the 340B program operates today, and they influence all of the stakeholders that we have been discussing in how they determine how they're going to maneuver the 340B program and its day-to-day operations. So we're going to drill down now into the prescription flow, and that is, how does a 340B purchased drug make it through the process of getting into the hands of a patient? Now, in your resource documents, I think Megan mentioned earlier, you've got a couple of handouts. This is one that has a pictorial that you will find, and it also has all of the steps that you'll see here, all 8 of them, mapped out, word for word, what happens and how it happens. Now, what you see in this diagram is actually how a prescription flows through a contracted pharmacy, because a contracted pharmacy is a lot more complicated in the, what I'll call, eligibility process as compared to a covered entity that has their own pharmacy where they are actually filling prescriptions in-house and getting those to patients. So they are doing the direct purchasing for those patients that they can see within their 4 walls of their either hospital or clinic. This is when you have patients that may not live close to the covered entity. They may live 40 miles away, they may live 75 miles away. And remember, when we're talking about a covered entity, it could be a rural hospital that is not close to a pharmacy necessarily where that patient lives. So it all starts with the patient having a visit at a covered entity. So that's step number 1. They must have an eligible visit. Just because a patient is part of a covered entity and has been at a covered entity, all of their prescriptions do not just automatically become eligible. They actually have to have a visit. They have to establish a relationship with that covered entity. Once that patient gets that prescription, it is either electronically submitted to the pharmacy, or it is walked in with a piece of paper and handed directly to the pharmacy, and it's processed. Now, in that process, the pharmacy does not know at the counter necessarily that that patient is 340B, because the 340B eligibility lives with the covered entity. What happens in the back end is what you'll see in steps 2 to 3 is where software comes into play that actually looks at that prescription, either the electronic version or it looks at the manually entered prescription paper that came through, and it does what's called an eligibility check. And it makes sure that that patient was seen at an eligible location at the covered entity. It checks the provider to make sure that the physician or the nurse practitioner who saw the patient is actually eligible and on the credentialed file for that covered entity. It looks at Medicaid eligibility. Is it a Medicaid patient or is it not a Medicaid patient? Because if it's a Medicaid patient, in most states, Medicaid, you must avoid what we call a duplicate discount, where the manufacturer can't provide a 340B discount and provide a rebate to the Medicaid program. So those are excluded typically from being eligible unless the covered entity and the state have decided that they are going to carve those in, and the state then says, we get the discount at 340B, and we're not going to go after the rebate. That's a very important check in this process. But we're also, again, looking at many other factors now with Medicare included as to whether or not it's a Medicare Part B claim. Once it goes through all of these eligibility checks, it's either ineligible because it failed one of the checks, or it becomes eligible. And in that eligibility process, it is done what we call retrospectively, which means the patient has left. It now goes through these checks to make sure that that visit did happen. And most visits are not done real time. They're done at midnight, a file is sent, and then that is uploaded, and it does all of the checks on a day-to-day basis. And it is done such that that particular NDC is then evaluated, and then it is put in what we'll call like a bank, which means it sets it up and says, well, there were 30 tablets, and until we give a whole bottle of 100, it's going to sit there until it gets to that 100 count. The wholesaler, once it does have the information from the software that says you've met one bottle, you will order it and it will go to the pharmacy. And again, it is the covered entity that pays for that actual drug. And then between the pharmacy and the covered entity, there is then an exchange of a dispensing fee for filling that drug and an administration fee for going through the process of all the eligibility checks. So in a nutshell, that is what happens in the background with every patient that comes through and is seen at a contracted pharmacy. Again, lots of checks in play to make sure that it is an eligible patient, because just because they went to that entity doesn't make them a patient 100% of the time. So your next question will be, okay, so we understand the program, we understand who all the stakeholders are, and kind of how things flow. What's happening in the industry today that is impacting 340B, and it's causing probably a lot more people to come into your offices and talk about the importance of 340B and what's happening to it. One of my favorite pictures is this particular chart. It's a chart of 340B over time, and it shows when 340B started in 1992, and then it shows towards 2010 when we had the Affordable Care Act that added additional 340B entities. You will see a lot of activity in the 340B program as far as how it was administered, when HRSA started doing audits, and some of the guidance that came out on how the program should operate. So I used to say quiet, sleepy program, and then in 2010, a lot of activity, and it continues on an annual basis with a lot of action on how the program operates from various stakeholders to present day. If we look at 2021, we'll talk through some of the challenges that the 340B industry as a whole is starting to see. And it all banks on some of the healthcare trend drivers that we are seeing in general. And my acronym for this is PEST, P-E-S-T, and that is we have politics involved, there's the economics of drug pricing at play, there is the social aspect, which is we have consumerism, we have people and patients who are a lot more in tune with what things cost because we have high deductible plans, prescription drugs have increased, and then you layer upon that technology and all the capabilities that technology does to put things more in front of us, so we have a lot more awareness. And all of this targets, again, on healthcare in general, and then this also has an overlay in 340B. So these are some of the 340B industry pressures that we're seeing today in 2021. And we'll start on the left, which is we have potential regulatory changes that have been knocking on 340B's door for quite some time. And so there are regulations that recently passed, as you'll have seen in that chart when we were going through the timeline, on what we'll call an administrative dispute resolution process, which is to help covered entities as well as manufacturers talk through challenges with the program that they would like to dispute with the federal government. That process just started. It passed in 2020, but it's just officially started in 2021, and it has had a very slow uptake in getting that process launched, and that's because of the government transition that we've been going through, moving from one administration to a new administration. So there's been some slowness in getting that moving. But there's also the risk of audit findings that both manufacturers as well as covered entities face in this program, and that the federal government typically does about 200 audits a year, and their proposal for this next fiscal year is to raise that to 250. And you may think, well, 250 doesn't sound like a whole lot, but when you actually look at the number of child sites that get audited through that 250, it's thousands of locations that actually go through an annual audit process. Then we see an increasing amount of PBM, so the pharmacy benefit management companies, as well as manufacturers, influencing on limiting access. So we have manufacturers that have determined that they will no longer make 340B prices available to contracted pharmacies. And we have PBMs who are now deciding to reduce reimbursement to the 340B covered entities, which means you're taking a federal government program that was designed to support the covered entity and the patient population they see. Now we have PBMs that are taking a chunk of that pie and putting that more into the PBM space, into the for-profit world. And then the last component is that we also now see many of the retail pharmacies that are participating in the 340B program mandating newer technology solutions. So again, just increasing some of the burden on the actual covered entity to make the program work and to make sure that their money that is coming in through that program goes to the actual covered entity. So your question probably is, well, why is all of this happening? What is happening in 340B? Why now? And why is there this market shift with manufacturers and pharmacy benefit managers? And this picture, it's like an onion. When you look at the center of the program, it is the 340B law, that Public Health Service Act that we talked about. That is what keeps the program whole. That is what the federal government administers. Then there are regulations that are created, and 340B as a program has very few regulations that regulate the program's day-to-day operations. Most of what it is in guidance. So that's the blue circle. So that's Federal Register notices that have a notice and comment period. That is where contract pharmacy lives today. So it lives in guidance. Then the outer circle are what we'll call frequently asked questions. And that is not enforceable in a court of law, but the federal government does have frequently asked questions where they post kind of what their interpretation is of the law or of regulation or guidance. So when we look at what is happening in the marketplace in this shift, pharmacy benefit managers are not in any of the guidance, regulations, or 340B law. The only thing in 340B law is related to Medicaid and avoiding duplicate discounts when Medicaid is the insurer, but not commercial, not Part D. Then when you take a deep dive into contract pharmacy was not written into the 340B law in the beginning because it was not top of mind. It wasn't until 1996, 4 years into the program, that covered entities started to vocalize to the federal government that they did not have an actual pharmacy where they could dispense medications. And that is how contract pharmacy came into play. And contract pharmacy is in guidance within the blue circle. So this is kind of where we sit today with some of the challenges that covered entities face when operating in the 340B space, is that they now have manufacturers who have a different interpretation of the 340B law, and you have PBMs that feel as if though they are not guided or regulated through any type of law when it comes to 340B. And so what we've seen happen with manufacturers, so as we shift gears, is manufacturers typically communicate to the 340B community through public notices on HRSA's website. What you'll see in the gray box, this is kind of what they usually communicate. If there's a limited distribution plan because maybe they have a shortage or they want to direct drugs specifically to a particular provider or a particular specialty pharmacy or a particular specialty distributor, this is where they publish this so that entities know. They also publish their overcharges when they inadvertently overcharge on their pricing calculations, or they have NDC changes. And the latest thing we started to see, which happened in 2020, was this limitation on contract pharmacy access. Now, if you look at the timing of these things, very few notices were done until last year. It skyrocketed. And that's when there was a loophole found in how the program is administered that manufacturers started to take advantage of this kind of void. So these are some of the models that we're starting to see take precedence in the marketplace. You'll hear covered entities come to you about limiting their access. That's one mechanism that is being utilized by manufacturers. The second is this data component. Manufacturers want to request data from the covered entities on all of their prescriptions that are eligible through the program. And then the third bucket is this rebate model, which is a model that is not in the guidance, it's not in the law. It's a very different way of entities being able to access 340B, which means they have to pay full price upfront, and then they have to prove to a manufacturer through a third party that they are eligible to get that money back. So again, the way the program was initially set up was a discount at point of sale so that you're not having to pay more for drugs, you're actually getting them at a reduced rate. And I think what a lot of people have come to the conclusion is that what these models have slowly been doing is eroding the 340B program as far as the entities either lack the ability to purchase and lack access, which what the ultimate goal is that it's decreasing the 340B purchases. And there are a total of 8 manufacturers that are now moving into these models. And the federal government has sent notices to the manufacturers, but it hasn't stopped. And a lot of that, like I said, goes back to that onion model that the manufacturers feel, though, as though the law doesn't particularly cover these, so they are proceeding in maneuvering to these newer models. To give you a sense of the dollar amounts that we're looking at, the 340B program is roughly about $38 billion as of 2020 in purchases. And when you look at the total spend in drugs in the United States, it's $535 billion. So 340B makes up roughly about 7% of total purchases. When we drill down into the 8 manufacturers that are now excluding contract pharmacy, they accommodate about 6% of all the 340B purchases, so small in the grand scheme of things. But they make up, for those 8 manufacturers, 39% of Medicare and Medicaid purchases. And again, if you recall, to participate in Medicare and Medicaid, you must participate in 340B. So these manufacturers are still participating in Medicaid and Medicare, yet they've excluded a portion of 340B from covered entities. And that 39% makes up about $51 billion in purchases through Medicaid and Medicare. So in our analysis, what we're looking at right now with the 8 manufacturers is it's about $1.8 billion in impact to 340B covered entities today. So that is money that is no longer going to the safety net, but it's actually being diverted back to the manufacturers. And they've been publishing those in their quarterly reports. So I have in this deck, if anyone is interested in what those models are, I have where the manufacturers are that are participating in the models so that you have a better sense of the types of models, how they operate, when they started, and kind of the background on the why. But at this point, what I'll do is pause for any questions that the committee may have, and looking forward to our dialogue.
Thank you. Okay, we'll start out with questions. We've got Senator Gossage.
Thank you, Madam Chair. Thank you for the presentation and the slide deck. I have several questions here. I'll try to make them quick. On page 14, it talks about how that HRSA does not restrict how entities use the revenue. You were talking about how there's some attorneys, some surveys that are done. So we're asking manufacturers to reduce how much they earn from these medications, but yet somebody else is profiting from the reduction, but HRSA is not overseeing how that profit is reimbursed. And by the way, I just want to say to the legislative staff, this document is very helpful. Thank you very much. So could you address that?
So your question, Senator, is why is HRSA not looking at the revenue?
Right.
Yeah, so part of HRSA's role is to administer the program, and again, not being written into the law as one of the things that they are responsible for doing. There has been comments made by the federal congressional members on how HRSA might be able to, as part of their audit process, to look at how the savings from the 340B program is generated and what happens with those funds. So again, it's one of those areas that is not spelled out specifically, but it is something that the federal government has asked for HRSA to have more oversight over.
Thank you. And on page 17, it lists the wholesaler in the graph. Are wholesalers PBMs, or who are these wholesalers?
Yeah, wholesalers are part of the what we'll call drug distribution system. So wholesalers have relationships with manufacturers to make sure that a manufacturer's product can be delivered to all different types of purchasers, whether that be a hospital, whether it be a pharmacy, retail chain, big box store. They're basically distributing drugs on behalf of manufacturers to those that need to purchase them.
Thank you. And so primarily PBMs, right?
PBMs are connected to insurers, so very different, disconnected from wholesalers. So a pharmacy benefit management company typically works in collaboration with an insurer to, again, negotiate prices that the insurer will pay in connection with working with a retail pharmacy. So in other words, I might have a insurance plan with a prescription drug card. Mm-hmm. I go to that pharmacy. The PBM has a contract with the pharmacy to provide that medication at a certain reimbursement. A PBM also has a contract with the manufacturer for that drug. So they have very different contracts between those different groups. And again, it's to get their drug on formulary. That's what the manufacturer wants. And then the PBM wants to negotiate pricing between them and the pharmacy that will actually fill that drug.
And just two more quick questions, if I may, Madam Chair. On page 25, we list that there are $38 billion represented within the 340B marketplace. However, then you list that the effect of not using the contracted or not working with the contracted pharmacies that some of the manufacturers are doing, the effect is $51 billion. Could you address that?
Yes. Let me go back to this chart. So the $51 billion is what a manufacturer, those 8 manufacturers today, mm-hmm. what their total purchases are in Medicaid and Medicare.
So it's
and
not.
Total,
go ahead.
Yeah, not 340B. Yeah, not 340B.
Okay, just wanted to clarify that. And
yeah,
then
the 340B purchases, just to be clear, the 340B purchases are mm-hmm. $1.8 billion.
Okay, thank you. And then finally, on page 24, when it talks about the rebates, is there any transparency on those rebates at all?
So this rebate model has yet to come to fruition. So I couldn't tell you whether or not it was transparent because it's administered through a third party. So the way it would work is I would buy a drug at full price, and I would have to submit to the manufacturer that I bought a drug at full price, and then the manufacturer would determine whether or not I was eligible to get a rebate. And I would not have transparency necessarily into that. I would be leaning on the manufacturer and their third party to tell me yes or no.
Thank you. And then finally, it says that states can't discount over the 340B. So there was something in your presentation where you said that it would be a
Medicaid.
choice, right, on Medicaid.
Yes.
So you were saying there is a choice between either the 340B price or that since the states cannot have a further discount on that, what was the other thing you said states could do or states are doing?
Yep. So states have two ways they can do things. They can carve out 340B, which means they are going to go after the rebates to the manufacturers. So you will not use 340B in those instances, and that would be a state law. The opposite of that is what's called a carve-in, where the state says, we want you to use 340B because we are not going to go after rebates. We believe your 340B price is a better price, and it reduces the labor entailed by having to go after rebates with manufacturers because it's right up front. The 340B program is the discount, and that's worked with the Medicaid program. So there's a separate dispensing fee, and you basically bill at cost acquisition.
And do we know which Kansas does? Maybe we'll find that out from other conferees.
Yes.
Thank you
Yes,
very
you
much,
will.
Madam Chair.
Representative Wolfmore.
Thank you, Madam Chair, and thank you for your presentation. I probably have a broader question, so I just want to make sure I understand this from your presentation. So this happened in 1992, and the intent of this legislation was to make sure that covered entities that treat disproportionate share of people who are uninsured, underinsured, Medicaid, so that they could provide more resources for them in terms of either helping them with drugs or helping them with other resources to serve their patients. So then I think what you're saying is where the rub comes in is when the PBMs, the sort of middleman, if they will, it sounds like, take a piece of that, and so that money doesn't flow down to the entity that it was designed to reach. Do I have that right?
That is correct.
Okay. And I think I had one more question. No, it was answered by Senator Gossage. Thank you very much.
Thank you.
Representative Landwehr.
Thank you, Madam Chair. And maybe I just wasn't following your charts, but I was trying to understand what the original intent and entities were, and then when exactly were the other ones added, and who were they?
Yeah, so the intent of the program was to stretch federal scarce resources. And what was happening at that time is the costs for prescription drugs were increasing in the early 90s. And hospitals were not able to receive discounts. And so 340B was essentially created to help those hospitals and help those clinics get access to drugs where the prices kept going higher. Now, those original hospitals were considered what we call DSH hospitals, so disproportionate share hospitals. In 2010, when the Affordable Care Act was passed, the entities that were added at that time were rural hospitals, so critical access hospitals, those hospitals with less than 25 beds. Sole community hospitals were added, as well as rural referral centers. So you'll see a lot of rural hospital designations. It also officially added children's hospitals at that time. So those were the entities that were added in 2010. All the other entities we talked about have been in the program since its inception.
Okay, if I might, Madam Chair. I guess it would help, because I think, some of your answer came from page 19. If we had better clarification, Madam Chair, on, what changes that happened in each one of these years and what was that impact? Because you come down, if you're looking at this as a layperson, let's just look at 2018, Medicare Part B
Yes.
cut. So what do you mean Medicare Part B cuts?
Absolutely. So in 2018, Medicare Part B cuts to reimbursement were made to hospitals. So in other words, it used to be if you were a hospital that billed for a Part B drug at that time, you got ASP, the average sales price, plus 6%. In 2018, if you are a 340B hospital, what happened was they reduced the reimbursement to ASP minus 22%. So it reduced the reimbursement that went to a 340B hospital. And that was done because Medicare was looking for savings. They knew that 340B hospitals received a discounted price. Therefore, the Medicare program made a change to how hospitals would be reimbursed. And that is under, currently, several lawsuits have been filed and is going through the court system. Actually, we'll be going through the Supreme Court in, I believe it'll have Supreme Court will hear that, and their final will come out in the spring of 2022.
Yeah, I think, Madam Chair, my request would be, because I like this chart on 19, is if we could get more detailed explanation of each one of those years, what occurred, just to get all of us up to speed on what entities that we're talking about. Because, like I said, you hear the word cuts, it's like, okay, cuts and a reduction,
Yep.
actual cuts, what did we do? So, but thank you, Lisa, this was helpful.
Absolutely.
And thanks for that suggestion. We'll add that in maybe for next meeting. Representative Landwehr.
I'm sorry, one other thing is to know exactly who the original entities were and as those entities were added into this program. Because I think it started out with what, like 3 or 4 different entities? And now we're up to several. Is that correct, or am I misunderstanding it?
No, it started out, if you look at the beginning of the program, so I mentioned these grantees that you see here, these have all been in the program since 1992. And the hospitals, there was only one set of hospitals at that time, which was the disproportionate share hospitals, DSH hospitals. So the additions that we talked about in 2010 were really to add the rural hospitals and officially add children's hospitals. And again, they all have very specific criteria that they have to abide by as far as being not-for-profit. And they have a percentage of, again, a disproportionate share of Medicaid, Medicare, and SSI numbers that have to be met in order to qualify.
All right, thank you, Lisa. And I think also the question that Senator Gossage asked on, where Kansas is at, I'm thinking they're the rebates, but I can't even tell you that off the top of my head.
Yeah, well, I think, we'll hear more about
You'll
that
hear about it.
later. Yeah. Senator Erickson.
Thank you, Madam Chair. Thank you, Lisa, for this very, very helpful presentation. I see on page 14 that Planned Parenthood is listed as a covered entity. It was my understanding. No, go ahead.
Go ahead. Yeah, Planned Parenthood Federation of America is what we're calling a member of the 340B coalition. So certain Planned Parenthood sites have qualified for Title X funding. So again, that is up for debate in different forums, but they have had sites that have qualified based on Title X funding that they have received.
Okay, it was my understanding they unenrolled in 2019. Did they re-enroll under a different?
No, they would not have.
FHQC or, okay.
No.
Okay, thank you. Thank you, Madam Chair.
Senator Pittman.
Thank you, Madam Chair. Just a couple of questions. Thank you, Lisa, for this excellent overview, and thanks for being an advocate for this program that helps so many of the disadvantaged out in our United States. One of the models you had was the Venn diagram that had rebate access and data. And presumably these are some of the ways that we can, that some entities are limiting, maybe limiting exposure to the program. How does data fit into that as a kind of an inhibitor on page 24?
Yep. So what started out as a limited access model was the first kind of attempt at limiting. Then it became access and data. So it's kind of why they kind of overlap. So in other words, there's, I think it's 4 of the manufacturers that require that you have to provide them data in order to receive the actual 340B price. And the data that they are asking for, they want to know all of the commercial data for the 340B program, which when we look at 340B from how the program works, the criteria around Medicaid, and I think nobody would ever say that Medicaid data would not be part of that picture. I think every covered entity wants to make sure there are no duplicate discounts with Medicaid. This model, when it comes to data, is really focusing in on commercial insurance, and that manufacturers want to know on commercial patients, they want to know that data so that they can reduce the reimbursement that covered entities today do receive as a result of participating in the program. And that is currently not a violation of the 340B program.
Okay. So they're looking at the financials of the situation, and do they actually pull in actual individual patient information into the manufacturers?
That has been their request. And a lot of the concerns that covered entities have expressed is, it's PHI. They don't feel comfortable providing PHI to a third party.
PHI being personal
health information. Yep.
Thank you.
That's correct. Yep. Personal health information for specific patients, including things like prescription number, the provider for that particular patient. And entities have expressed that in order to do that, they would need to have a business associate agreement, a BAA, with anybody to do that. But these companies today do not sign BAAs, and so a lot of your covered entities have said this is not something they can participate in because it leaves them very vulnerable from a patient health information perspective.
Sure. And just another set of questions, just maybe one or two. Later on in this day, we're going to hear from a few other entities that have gone through other timelines, it looks like. And one of the things that seems to be popping up inside of the testimonies is there seems to be quite a bit of ambiguity in the original act and in the later act, that the HRSA has got a lawsuit out there back in, I guess it's 2020, stemming from they want to reduce the number of duplicate discounts, obviously, like you were mentioning. But it seems like there's some holes that are out there that the courts are saying are in gray areas. And since you're not going to be coming back on the mic, I thought you might want, I don't know, just to kind of talk about the fact that there do seem to be some gray areas inside, that the HRSA seems to be using precedent, and it's not really spelled out in the statutes. So there seems to be a hole, and then if I look at other kind of testimony, it looks like certain states are jumping in to cover up those holes or to at least interpret them. So it seems like the states are being required, or at least stepping up into fixing different holes, and we're having a patchwork of regulation across the states here, potentially. I mean, could you comment on that?
Absolutely. So I would tell you that the Medicaid program that HRSA integrates with CMS is really been focused on fee-for-service. That's what is written. It's in their federal guidance. They've had a lot of clarity in that. What is less clear, because when 340B originally started, remember in 1992, managed care Medicaid was, again, not in anyone's future projection. So managed care Medicaid is often what we'll call silent in HRSA's guidance. So states have taken initiative with CMS and done things at the state level to build more clarity on managed Medicaid versus fee-for-service, because a lot of entities, or not entities, a lot of states have moved away from traditional fee-for-service and moved more into a managed Medicaid space. Hopefully that gives you clarity, at least on that front. As far as PBMs are concerned, there is no guidance that HRSA has. There's nothing in the law that helps them to actually provide any type of guidance to covered entities, except to work collaboratively with those parties to come up with a agreement between them. So their guidance in that has been, again, not very supportive of the covered entity and the PBMs actually coming to a conclusion. It leans on the covered entity to just have a business discussion, because it's not in the law. That it is completely silent. And that's why you're seeing the states having to intervene a lot, and you'll hear later in the day about some of the rationale behind that, and why states are needed to help protect covered entities, because there is no protection in the federal law. And I think Bill Von Olson will be discussing that probably in much more depth later.
Yep. Thank you. Thank you, Madam Chair.
Any further questions? Were there any questions online? Okay, thank you, Lisa.
Thank you. I appreciate the opportunity. You guys have a great rest of your day.
Okay, we are going to move to our next speaker. And I have a page-long bio for him that you don't have, but I think are we going to, okay, rather than me read his whole bio, we're going to get these printed for each person. But Mr. Van Osen was another speaker that I learned about through NCSL. And he is, well, you'll read about it, but he's with a law firm, Powers, Piles, Sutter, and Verville. And this is a Washington, D.C. law firm. And he, I believe, well, he has more than 30 years' experience with this pharmaceutical pricing. So do we have him online? Okay, Mr. Van Osen. While we're waiting, to be fully transparent, Mr. Van Osen had a fee for his time for this, and I thought that his testimony was really important for this, so I reached out to the FQHCs to cover the fee for his testimony. Mr. Van Osen. Von Osen.
Can you hear me?
We can hear you now.
Oh, good. Okay, so I am relying on someone locally to advance the slides.
Okay, we don't have slides up just yet.
Okay. While we're waiting, just a few words about myself. Yeah, I go back to the very beginning of the 340B program. I was representing the National Association of Public Hospitals, which represented state and local hospitals around the country. The original legislation only extended drug pricing discounts to grantees and sub-grantees. So my job was to extend the program to hospitals, which we were able to do in a bipartisan way. And we were also involved in 2010 when the 340B program was revisited by Congress. We drafted a number of provisions to increase the integrity of the program, and we also added 5 categories of hospitals, mostly rural hospitals, to the program, which should have been included originally, but were not, as well as children's hospitals. So I've been representing the interests of safety net providers really during my entire legal career. And you can move to the next slide. And in addition to representing 340B providers and provider groups, we also do a lot of work with state Medicaid agencies, strategizing on ways to lower the cost of drugs for state Medicaid programs. So I wanted to share that as well as to make clear that these slides are based on my own views and should not be relied upon as legal advice. Next slide. Okay, so here's the agenda. I'm going to touch on a number of areas: discriminatory reimbursement, federal efforts to address the problem of discriminatory reimbursement, then focusing on the intersection of 340B and the Medicaid drug rebate program, and how manufacturers have to be protected from providing both Medicaid rebates and 340B discounts on the same drug, often referred to as duplicate discounts. Then I'm going to touch on, really the declaration of war by the drug industry against the 340B contract pharmacy program. I'll talk about state opportunities to partner with the 340B program, and then I'm going to conclude with a summary of opportunities that I think your legislature has by partnering with the 340B program. So in some ways, I think my presentation is kind of laying a foundation for specific recommendations of legislative actions that that your body can take. Next slide. So, forgive me if I'm repeating what Lisa said. I think I'm going to be touching on a lot of the issues that Lisa addressed. I'm an attorney, so I'll be addressing those issues from more of a legal perspective. But I do want to start with the purpose of the 340B program. As Lisa said, it's to stress scarce resources so that the safety net providers can provide more services and treat more patients. But at its core, the 340B program is a tax relief measure. If you look at these covered entities, they are all highly dependent on taxpayer support. So that's certainly true with federal grantees and sub-grantees like federally qualified health centers and Ryan White clinics. But a lot of these grantees are state and local health departments. So in addition to getting federal grant money, they're essentially supported by state and local taxpayers. A lot of public hospitals are in the 340B program. State university hospitals, county hospitals, city hospitals, almost all of them qualify for 340B. And then there are a lot of state and local governments that have contracted with nonprofit hospitals to serve indigent populations. They are also included in this program. So these covered entities provide care regardless of the patient's ability to pay. Our country does not have national health insurance, but what we do have is a network of safety net providers across the country that will treat anybody regardless of their ability to pay. But because they can't pay, that means that these safety net providers have significant levels of uncompensated care, and that is a real problem in our country, is how to compensate these safety net providers that are caring for uninsured or underinsured patients. So the 340B program offers an alternative. You know, historically, taxpayers would be asked to cover the cost of uncompensated care, and we have lots of federal and state programs intended to cover uncompensated care. But the 340B program is essentially asking the pharmaceutical industry to do its share in addressing the problem of uncompensated care. And, you know, I should say it's a voluntary program. Manufacturers are required to participate as a condition of them having their drugs covered and reimbursed by the Medicaid program and Medicare Part B, which are obviously large segments of the drug industry in our country. If the drug companies are willing to forego coverage and reimbursement of their drugs by Medicaid and Medicare, then they don't have to participate in 340B. And there are a number of drug companies that have opted out of the 340B program in that regard. But the lion's share of the drug companies do participate. They, you know, the Medicare and Medicaid programs are just too important to them. And so they have agreed to give the discounts to these safety net providers as a condition. And so in a way, they're doing their share to address the problem of uncompensated care in the U.S. Next slide. So this purpose is achieved in two ways, and it depends on the patient. So if the covered entity is treating an uninsured or underinsured patient, basically the covered entity is going to lose money by caring for those patients. By lowering the cost of drugs that those patients need, the covered entity essentially loses less money. So that's one way the 340B program supports safety net providers and addresses the problem of uncompensated care. The second area is for insured patients. So for insured patients, these covered entities are allowed to bill third-party payers. But because they're buying the drugs at a lower price, they're consuming less of their third-party reimbursement on paying for outpatient drugs. So that leaves them with more revenue for patient care. So those are the two ways that the 340B program generates additional resources for safety net providers without asking taxpayers to cover those costs. But the second method of relieving taxpayers of uncompensated care is frustrated if the reimbursement for outpatient drugs is cut by third-party payers. And that is the crux of the problem with discriminatory reimbursement, which I'm going to talk about next. Next slide. So really over the last decade, we have noticed a growing number of insurers and their pharmacy benefit managers requiring pharmacies to identify when they use 340B drugs to fill prescriptions and to reflect that on their claims, which then triggers a different reimbursement mechanism, and that reimbursement is inevitably results in lower payments to the pharmacies. So it is basically the PBMs and the third-party payers have sort of two-tiered reimbursement systems, one for pharmacies that use 340B drugs and those that don't use 340B drugs. And this is viewed as a direct attack on the 340B program because, as I pointed out, the way the 340B program works is to generate resources that these safety net providers can use to treat uninsured and underinsured and other vulnerable populations. And by eroding the reimbursement that safety net providers receive, these payers are actually at risk of shifting the burden back to taxpayers. So we're trying to avoid having to ask taxpayers to cover the cost of uncompensated care. And, you know, there's nothing in the legislative history of the 340B program that it was intended to save money for private insurance companies and PBMs, almost all of which are for-profit. The 340B community is united in the belief that this is really an abuse of the 340B program and undermines the program's intent. Next slide. And it's not just the safety net providers that hold this belief. The agency that administers the 340B program feels exactly the same way. There are a number of guidance documents that articulate this belief. The federal government itself admits that these lower reimbursement rates for 340B drugs are undermining the purpose of 340B. Unfortunately, HRSA doesn't have the authority to address this problem because the 340B statute only addresses the purchasing and the price of drugs, not how drugs are billed and reimbursed. I'll talk about how Congress is trying to remedy that oversight, but we're not there yet, and essentially the states have stepped in the meantime. Next slide. So, in addition to HRSA recognizing that this is a problem, we have reports from the Government Accountability Office that has documented all the ways that covered entities are using 340B savings and revenue to care for vulnerable patients. These are just some of the ways that covered entities do that. And I do want to say that covered entities have a fair amount of discretion in how they use their 340B savings and revenue to treat patients, which, you know, only makes sense because it really depends on the public health needs of their service area. I mean, if the 340B hospital or clinic is in an area where there are lots of individuals with diabetes, for example, then they can use their 340B savings and revenue to develop special diabetes programs. But in other service areas, there may not be a problem with diabetes. So it really doesn't make sense for the federal government or Congress to be telling these safety net providers how to use their savings. That's really a local decision that's driven by the needs of the patients in the community. And so if you go to these GAO reports, you'll see that there's a very wide array of ways that 340B entities are using their savings. I'll tell you, one of the biggest is just case management. You know, we have a very complex healthcare system, and these vulnerable patients don't have the resources to navigate our healthcare system, figuring out where to receive care, who can help pay for care, how to get from their homes to their doctors. There are lots of forms that have to be filled out. They may not have access to the internet. There are just so many barriers to care. And what a lot of these 340B hospitals and clinics do is they use 340B to pay for case management services to basically link these vulnerable patients to care, and because they wouldn't get the care in any other way. And case management, believe it or not, is typically not reimbursed specifically by payers. So even individuals who may have insurance may still have the same problems navigating our healthcare system. And this is especially true with the delivery of medications. You know, so much of healthcare these days is taking the proper drug, and often it's multiple drugs. And when you're on multiple drugs, the risk of drug-drug interaction problems, side effects, is greatly increased. And so you really need medication therapy management to maximize the outcomes of treating patients through medication therapy. Medication therapy management, again, is often not covered by third-party payers. So this is another area where the 340B program is being used to ensure that patients who need the care most are getting the care that they need. I should also say that covered entities are on the front line of caring for patients with COVID, and a lot of their 340B savings and revenue are helping to underwrite the cost of battling the pandemic in this country. Next slide. So I've been focusing just on the problem of PBMs cutting reimbursement, and that is, the primary problem. But there are other tactics that PBMs use to the detriment of 340B pharmacies. So I've listed them here. They can reduce the dispensing fees. PBMs pay for the drug itself, but they also pay for the delivery of the drug, which is often called a dispensing fee. So sometimes the PBMs will pay us lower dispensing fee to 340B pharmacies versus non-340B pharmacies, or they hide the reduction in reimbursement as a post-adjudication clawback. So they, after the drug is paid at the full non-340B rate, they go back afterwards, often perform an audit. They discover the 340B drugs were used, and then they claw back unilaterally. They take basically, they pay themselves back out of future reimbursement, or they impose administrative fees, things like that. Sometimes PBMs will outright exclude a 340B pharmacy from its network so that the patients insured by the PBM can't even use the pharmacy without paying out of pocket for the use of that pharmacy. More frequently, though, PBMs establish other kinds of barriers to participating in a pharmacy network. They will, for example, impose burdensome claims identification requirements. They'll subject them to increased audits. They'll have provisions in their pharmacy participation agreements that prevent them from disclosing to anybody these discriminatory practices, often called gag clauses. So these are barriers to being in these networks that are also problematic. And then I guess the last area is really restrictions on patient freedom of choice. The PBMs often require that for certain drugs, especially specialty drugs, that the individual use the PBM's exclusive mail-order pharmacy, which then precludes that individual using the covered entity's pharmacy or contract pharmacy, which means that even though those prescriptions are 340B eligible, the fact that they're being filled by the PBM's pharmacy rather than the covered entity's pharmacy means that the covered entity can't collect any reimbursement for those drugs, which again goes back to the problem of undermining the 340B program and shifting the burden of uncompensated care to taxpayers. So this is another PBM practice that we've heard lots about from covered entities, and covered entities have complained about and asked for relief. Next slide. So all of this is to provide an explanation as to why state legislatures are stepping in. And we've got 15 or 16 states that have addressed this growing problem by passing 340B anti-discrimination bills. And they address all the problems that I've just described for you. Some of them actually set a floor on reimbursement. They basically say, you can adjust reimbursement, but it cannot go lower than a floor, and that floor is typically the national average drug acquisition cost, which is a database maintained by the Centers for Medicare and Medicaid Services. It's based on empirical data. Basically, a CMS contractor surveys retail pharmacies across the country and finds out exactly what they paid for the drugs that they dispense in those pharmacies. And those prices are then averaged out, and they're provided to the public on the CMS website. It's called NADAC, which is the acronym. So that's sort of the average non-340B price that pharmacies pay. So it's a good way, it's a good benchmark, I think, for using to protect against discriminatory reimbursement, because that's typically what pharmacies pay for non-340B drugs. But these laws also protect patient freedom of choice and basically have general prohibitions against discrimination based on 340B status. Next slide. We do have some states that have chosen to regulate PBMs more generally. They're not focusing specifically on 340B. Any willing pharmacy laws, subjecting PBMs to licensing, auditing, credentialing, et cetera, et cetera. And these laws can be used by 340B entities to help address some of these discriminatory practices. But frankly, it's a lot harder for them because they don't specifically reference the problems of 340B. So we think a much better way to go is to have specific 340B anti-discrimination legislation. And often if you look at the 340B laws passed in other states, they tend to be part of larger PBM reform bills. And so the pharmacy community has teamed up with the 340B safety net community to advocate jointly for PBM reform that addresses both these 340B issues that I mentioned, but also addresses other PBM practices that are problematic, like DIR fees and unfair credentialing requirements and things like that. And I should say that the right of state legislatures to enter this area of regulation received a significant boost with a Supreme Court case that came down last year called the Rutledge case. The Supreme Court ruled under the Rutledge case that state laws regulating PBMs are not preempted by the federal ERISA law. And although it just dealt with ERISA, I think PBMs often invoke federal preemption as a reason why states cannot regulate them. And the fact that the Supreme Court in Rutledge disagreed with those preemption arguments, I think provides, strong support for states to legislate in the area of PBM regulation. So even though states may be subject to some legal challenges by the PBM industry, in light of the Rutledge case, and there are other cases that are already citing Rutledge, I think it's less likely that the PBMs are going to win those kinds of cases. Next slide. So the next few slides are charts. We are counsel to a national organization called Ryan White Clinics for 340B access. They're Ryan White HIV/AIDS clinics all across the country. And it was formed 5 or 6 years ago to basically advocate on behalf of the Ryan White clinics to protect 340B. The 340B programs come under attack primarily from the pharmaceutical industry, but also the PBM industry. And so because it's so vitally important to Ryan White clinics, this organization was formed and they hired us to help represent them. And one of the things, and discriminatory reimbursement is one of their top advocacy issues. And so one of the things we've done is prepare this chart analyzing all of these state laws prohibiting discriminatory reimbursement. And you'll see in the left-hand column different ways that states have chosen to address the problem. And some state statutes are more comprehensive than others. This first chart are the early laws that were passed in 2019. But if we go to the next chart, we now move into 2020, and we start seeing that these laws are, more comprehensive. So Utah and Ohio, for example, are more comprehensive. And so those are often models that we recommend to other states. Next slide. And now we move into 2021. If you look over at Arkansas, they passed their law in May. It checks all the boxes, so it's the most comprehensive, and for that reason, we think it's probably the best model for a state like yours that may be considering similar legislation. Next slide. Yeah, 2021 has been a banner year for these kinds of laws. These are the laws that are actually passed, but there's even more that are just pending in other state legislatures. But here's Tennessee is another good example of a comprehensive law that would serve as a good model. Anyway, let's keep moving. Next slide. So, as I said, there's 14, 15 states that have passed 340B anti-discrimination legislation. And I think quite rightfully, the safety net community has said, well, why isn't Congress stepping into this area? Well, Congress is trying to. As a result of the PROTECT Act, H.R. 4390, that was introduced in July by 2 members of the House. It's got 47 co-sponsors so far, which is a very good number, and increasing every day. And it's a bipartisan bill. And I believe 2 or 3 members of the Kansas delegation are already co-sponsors. We hope for more. And the PROTECT Act is very similar to the state anti-discrimination laws that I've just described. They have general prohibitions against discrimination. They protect patient choice so that they're not forced to use these exclusive mail order pharmacies. They're protected from burdensome claims identification requirements. But there's something unique in the PROTECT Act that I want to spend a little bit of time talking about, and that is it would create a national clearinghouse to protect manufacturers from duplicate discounts on Medicaid drugs. So this is, I'm shifting now into an area where the 340B program intersects with the Medicaid drug rebate program. And there is a need for regulation in this area to protect manufacturers. And so this is another area where, your legislature might be interested in addressing. Next slide. So I'm just going to step back and just try to explain what this duplicate discount problem is. The Medicaid drug rebate program was created in 1990. It requires manufacturers to pay rebates to state Medicaid agencies as a condition of Medicaid covering and reimbursing those drugs. And that basically saves money for the Medicaid program, brings down the cost of those drugs for state Medicaid agencies, and the federal share gets shared back with the federal government. 2 years later, Congress created the 340B program, requiring manufacturers to give an upfront discount to these safety net providers. Well, these safety net providers serve lots of Medicaid patients. So when Congress enacted the 340B program in 1992, it recognized that it was exposing manufacturers to the risk of giving both a Medicaid rebate and a 340B discount on the same drug. And everyone agreed that that was unfair, and therefore the law specifically prohibits manufacturers from these duplicate discounts. So this chart shows how a duplicate discount could occur. The covered entity buys the drug at a 340B discount, dispenses to a Medicaid patient, bills the Medicaid program, and then the Medicaid program submits the claim to the manufacturer requesting a rebate. And if the manufacturer pays the rebate, it's now given both a rebate and an upfront discount on the same drug. Next slide. So this problem has been essentially solved for drugs that are reimbursed directly by state Medicaid programs called fee-for-service drugs. Basically, the federal government has established a Medicaid exclusion file. The covered entities submit their Medicaid billing numbers if they're using 340B drugs when they bill Medicaid. And so Medicaid agencies, whenever they receive a claim under that billing number, know to exclude that from their rebate files. And so that way manufacturers are not paying the rebate. That's if the covered entity chooses to carve in to use 340B for its Medicaid population, but covered entities can also choose to carve out so that they're not using 340B for the Medicaid fee-for-service population, which then frees up the state to collect the rebates. So there's a good system that's working on the fee-for-service side. The problem is on the managed care side, if you'll go to the next slide. So when the rebate program was created in 1990, it was only on fee-for-service drugs. It wasn't until 2010 that Congress expanded the Medicaid drug rebate program to include drugs covered by managed care organizations. And Congress was already thinking about the duplicate discount risk. So when it expanded the rebate program, it only did so with respect to non-340B drugs. So it basically tried to preserve the 340B program from Medicaid managed care, tried not to disturb it. They only expanded the rebate program to non-340B drugs, which of course then would alleviate the problem of duplicate discounts. But the problem is states are having a very difficult time identifying these 340B drugs and excluding them from their rebate requests. And if you go to the next slide, there have been a couple of reports by both the OIG and the GAO discussing how states are having a very hard time protecting manufacturers from duplicate discounts on Medicaid managed care claims for a variety of reasons, which I won't get into. But the point I want to make is that there is a pretty simple solution to this problem. Next slide. Which is to create a clearinghouse. Now, interestingly, manufacturers have already sort of recognized this idea of a clearinghouse. And so companies like Sanofi and Novartis have contracted with a consultant called Second Sight that's developed a web-based platform called 340B ESP. And basically, it requires that covered entities submit their 340B claims so that the manufacturers then know if they're getting a rebate request they can then link that up to see if they paid a 340B discount, given a 340B discount on the drug involved in that claim. And then there's another company called Calderos that has developed sort of a different approach, but the same concept of trying to protect manufacturers from duplicate discounts. The covered entity community is united in their opposition to these manufacturer programs for a number of reasons. One is that these are private consultants working for drug companies, so they're not neutral in any way, and there's a real concern that the drug companies will use the claims data for other reasons. And we know that drug companies don't like the 340B program to begin with, so they could use the claims data, for advocacy purposes. But there's also concerns that supplying this information could create exposure under HIPAA and state privacy laws. So getting back to the PROTECT Act, one of the things it would do would be to establish a clearinghouse that would be neutral. It would be operated by a government contractor. So it's not being operated by someone who works for the drug companies or someone who works for the covered entities, someone who works for the government. And it would be in the position of sorting through all the rebates being requested of manufacturers by states and all the 340B claims and make sure that the 340B claims are backed out of the rebate request. It's really a simple step, but we need a neutral party to effectuate that. So I say all this because I know states are looking at creating this clearinghouse at the state level. We'd love to get it established at the federal level, but maybe in the meantime, states could do this at the state level. Next slide. So I'm going to shift gears again. I know Lisa talked about essentially the war that's been declared against the contract pharmacy program by the pharmaceutical industry. Covered entities have been using contract pharmacies to serve their patients going back to 1996. And it's largely because a lot of covered entities, especially small ones, don't have their own pharmacies. So when the 340B statute was enacted, federally qualified health centers, Ryan White clinics, state and local health departments that didn't have their own pharmacies, went to HRSA and said, we can't take advantage of this law because we don't buy the drugs. But what we do is we rely on community pharmacies to dispense drugs to our patients, and we often pay them for their services, and they bill third-party payers as necessary. And so can we basically use community pharmacies to dispense our drug? We'll buy the drug. So it's a ship-to-bill-to arrangement, which is commonly used in the pharmaceutical drug distribution system, where one party buys the drugs, but the manufacturer or wholesaler ships the drug to an agent who's essentially dispensing the drug on behalf of the covered entity. And that's really what the contract pharmacy program is. And when HRSA recognized in 1996, it basically said that covered entities already have this right under state law. We don't need it specified in federal law. They can use an agent under state law. Anyway, even though the contract pharmacy program has been in existence since 1996, we have 8 manufacturers that have unilaterally set restrictions. They've withheld 340B pricing on drugs dispensed by contract pharmacies, subject to certain exceptions. And HHS and HRSA have taken preliminary enforcement actions against them, sent them cease and desist letters, which then prompted 6 of those 8 drug companies to file suit in federal court to block enforcement. Next slide. So it's been a very busy year and a half, representing covered entities. Our firm has actually represented some of the covered entities in the lawsuits and been submitting amicus briefs in these 6 lawsuits that are pending. I'm not going to, this is sort of a timeline just showing you all the different drug companies that have developed these unilateral policies and the lawsuits that have been filed. Next slide. So that was last year. It's just as busy this year. HHS escalated the conflict. After sending the cease and desist letters, they've now referred the matters to the Office of the Inspector General to impose civil monetary penalties. The drug companies are seeking, some of them are seeking temporary restraining orders to prevent the imposition of CMPs. So as I say, it's all out war at this point. Next slide. We have broken down each of the lawsuits and all the details of each lawsuit, the claims being made and the status of those arguments. We don't have any resolution of the cases yet. We're expecting probably the Lilly case will be the one where we get a decision first. Oral hearings have been held, and we're waiting for a decision any day now. We just heard this past week the hearings in the AstraZeneca case, and so we may be getting a decision in that one as well. Next slide. And these are the other cases. Next slide. And this sort of gives you a breakdown of the causes of action. Some of them are challenging an advisory opinion. Some are challenging a rule, an administrative dispute resolution rule that covered entities are using to seek recoupment from these drug companies. The drug companies say the ADR rule is procedurally flawed, so some of them are challenging the rule. I mean, as I say, it's all out war, and you know, every cause of action is being alleged that can be. Next slide. But the point I really wanted to make is that at least one state legislature has stepped into this area and has said that, you know, because it's going to be years before these federal lawsuits are resolved, because, you know, one thing we know is that the losing party will certainly appeal their case to the Court of Appeals, and we may get conflicting decisions at the federal appellate level, and then often it goes to the Supreme Court to try to resolve disagreements between the different circuits. So all of that takes time, and meanwhile, covered entities are suffering every day, and it's not just them; it's their patients, because with reduced resources, they can provide fewer services and treat fewer patients. And we have lots of stories of how patients can't get their prescriptions filled because these covered entities don't have the resources to help subsidize the filling of those prescriptions. And there are other ways that the loss of the revenue from these 8 drug companies is harming patient care. So the Arkansas legislature has tried to bring more timely relief to covered entities. And earlier this year, they enacted Act 2021, number 1103, Section 1 that had, you know, 2 sections that essentially say that, you know, for covered entities in the state of Arkansas and for pharmacies in the state of Arkansas, manufacturers cannot withhold 340B pricing. And so that law, of course, prompted litigation by pharma in this case. Pharma went to court, got a temporary administrative stay, which is going to expire on the 26th of this month, but they've just filed last week a lawsuit in federal court seeking a permanent injunction against the law. We think that the state has better arguments here, that the state has all the right in the world to legislate in this area. So this is another area where states may be able to partner with their 340B entities to protect them by following Arkansas's lead. Next slide. So I just wanted to say that, you know, there's a long history of states working with 340B entities to save money on the cost of drugs for state taxpayers. We see it especially in the correctional area. You know, maybe almost half the states have worked with covered entities to make sure that their state prisons are partnering with 340B entities to care for prisoners, and then the covered entities share their savings with the state, so the state then saves on the cost of drugs. And, you know, states spend a lot of money on drugs, very expensive drugs, HIV drugs, hepatitis C drugs. Texas was the first to do this. They passed legislation back in 2001 requiring a partnership between their state correctional system and the state university hospital, which was in the 340B program. And other states have sort of followed that lead. But it doesn't just have to happen in the correctional area. It can happen, these partnerships can be established in the mental health area, long-term care, state employees. Basically, wherever the state is paying for all or part of the cost of the drugs, by partnering with 340B entities, they can save literally millions of dollars for state and local taxpayers. So I just wanted to point that out if you're sort of looking for ways to legislate in the 340B area. Last slide. So just to summarize the areas where, you know, you all could potentially legislate in the future, of course, it's the area of discriminatory reimbursement. As I pointed out, there are 14 or 15 states that have already passed those kinds of laws. And the covered entities in your state are suffering from the same PBM discriminatory practices as covered entities in these states. So your legislature could pass a law similar to those, and we would say, you know, Tennessee, Arkansas, Ohio are good models. Another area would be to address this duplicate discount problem for Medicaid managed care. My guess is if you talk to your state Medicaid agency, they would agree that this is a difficult area to protect manufacturers. And in general, state Medicaid directors have been supportive of this idea of a neutral clearinghouse for reviewing 340B Medicaid claims. So that's another thing that your legislature could do. Third, you could consider following the lead of Arkansas to defend the contract pharmacy in Kansas by enacting legislation similar to Act 1103 that would basically prohibit manufacturers from establishing restrictions on contract pharmacy arrangements. And then lastly, you all could promote the use of covered entities to care for state-funded populations in the areas like corrections, mental health, state employees. So that's my presentation. My contact information is on the last slide, and I guess we'll stop to see if there are any questions.
All right, thank you. Committee, do we have questions? Representative Landwehr.
Thank you, Madam Chairman. When I look up the Rutledge, Arkansas case, I'm seeing, from what I'm reading, it's more about PBMs, but not really about 340Bs. And it was, my understanding is, so that ERISA groups would be able to, would be impacted by some of the state, would not be impacted by some of the state PBM laws. Is that correct? It dealt with PBMs, not 340B?
Well, that's right. It addressed the right of states to regulate PBMs, in particular PBM payment rates. And ERISA does have a preemption provision, and the question is how broad is that preemption provision? And the Supreme Court, ruled that that there are limits to preemption, and that there is ample room for states to regulate PBM activities. The Rutledge case was really focused on reimbursement rates, that's protecting against undue reimbursement cuts, unfair rates that are too low. And the Supreme Court said that's an area that states can actually regulate, notwithstanding ERISA. But a big question is, what other areas can states regulate without being preempted under ERISA? And those are the issues being addressed in other cases across the country right now.
Okay, and Madam Chair, and the reason I asked that was because I've heard the Rutledge, Arkansas case brought up several times in discussions with folks, and when I dived into it, because it keeps being referred back as a case that allowed et cetera, et cetera, et cetera, for 340Bs, but it didn't. It's all about PBMs. So I guess that's where, Madam Chair, I'm having some confusion on this, is what we really have out there as far as, the court cases that are telling us that we're addressing 340B. My second question would be, 340B is a federal program with individual contractual agreements. So how do the states then really get involved with these contractual agreements?
Well, as an initial point, contracts are governed under state law. Contracts are a creature of state law, not federal law in general. But I'm trying to understand that your statement that the 340B program relies on contracts. For covered entities to participate in 340B, they don't have to enter into contracts. The only contracts that I'm aware of in the 340B program is with respect to these pharmacies that I was just describing, where covered entities are contracting with pharmacies to essentially dispense the drugs on their behalf. And so the covered entity buys the drug, pays the pharmaceutical manufacturer for the drug, but the drugs are shipped by the distributor to the pharmacy, and then the pharmacy can only dispense those discounted drugs to the patients of the covered entity. The pharmacies can't use them for their retail population. They can only use it for the patients of that covered entity. So that's the model that's at the center of these lawsuits that I just reviewed. And there is a states' rights issue here because, contracts are governed under state law. So I think, a lot of states feel that it's perfectly permissible for covered entities to use contract pharmacies as a matter of state law. And therefore, it's not something that had to be addressed in the 340B statute in the first place, because it's governed under state law, not federal law. Hopefully that makes sense.
It might to you, but it doesn't to me. And I think that's, part of our rub, Madam Chair, is us trying to get clarification on that of the federal responsibilities versus the state responsibilities in this program. Thank you.
Further questions? Senator Gossage.
Thank you, Madam Chair, and thank you for this testimony today. I had shared the same question with Representative Landwehr. One of my concerns is we received this chart from both Sentry Data Systems as well as the earlier conferee regarding eligibility process flow, and I asked where did the PBMs fall and ask if that was the wholesaler. I'm not really seeing where the PBMs are involved in this whole eligibility process flow where it goes to the patient. Could you address that?
Sure, yeah. And in some ways, you've identified the very problem that we're trying to address, because the 340B statute does not address PBMs or any payers. The 340B focus, the 340B program is focused on the sale of drugs from pharmaceutical manufacturers to these safety net providers. That's only the first step. The safety net providers then dispense or administer the drugs to their patients, and if the patient has insurance, then the covered entity or its pharmacy would bill the payer, which in most cases is the PBM. And the PBM then is now cutting reimbursement because the drugs being billed were bought at a lower cost through the 340B program. Congress didn't anticipate that problem. So there is no registration process for PBMs because PBMs fall outside the scope of the federal statute. Now, if the PROTECT Act is passed, then federal regulation would be extended to these discriminatory practices by PBMs. But it's just a bill that's been introduced, and although it's gathering considerable support, it hasn't passed Congress yet. So that's why states are stepping in to fill the gap. And so the point I want to make is that your legislature has that opportunity like that of other states.
Thank you. The law that was passed, the federal law that was passed in 2020 that went into effect in January 1 of 2021 that prohibited PBMs to be part of the safe harbor that was originally intended for purchasing organizations. That did seem to help that they were getting paid on both ends from the manufactured side as well as the insured side. What I have to agree with Representative Landwehr that I'm not seeing here, and I visited with Senator Bartow from Arizona, and then also the representative, or it was the senator from Arkansas at a recent ALEC conference regarding that very law that they have, and that's one of the reasons why I guess it's currently in litigation, is regarding the contract situation. So I would like to know, one, you speak a lot about the covered entity. I feel like the patient's getting lost in this discussion. The covered entity is protected here, make sure the money goes to the covered entity. But I have seen patients who have received excellent, oftentimes zero costs for their medications by going through the mail order, through the PBM. I'm certainly not here to protect PBMs in that I testified about the Safe Harbor bill in DC. So I would like to see this focus today, in my opinion, Madam Chair, to be more on the patient as opposed to on the covered entity, and that what we would want to do is make sure that they were protected. Is this going to help them? What about their cost of medications as opposed to are we putting money, giving money to the covered entity in the form of revenue that we're taking away from the manufacturer through the 340B? Could you address that?
Well, absolutely. And I think if you asked any federally qualified health center, Ryan White Clinic, rural hospital, or any of the other 340B entities, they would say that the 340B program is the best way to support patient care. I mean, if you just pass discounts through to patients, you would be missing a huge opportunity to address all the other barriers to care that vulnerable populations face. I mean, we do a lot of work in the Ryan White HIV area, and HIV medications are very expensive. And so if patients had to pay the full price for those medications, they wouldn't be able to take them because they can't afford them. But that is just one problem. A lot of people with HIV don't even know they have it. So the first step is to make sure they get tested. Well, if they're tested and they're found to be positive, then you've got to get them into care. Well, you know, then you get into issues like transportation, finding a provider that will care for them. Linking them to care is a big challenge, and then keeping them in care. And then finally, if you overcome those challenges, then you get to the medications. Then you get to the issue of, okay, well, proper care means taking these daily HIV medications, and you've got to stay on your drug regimen for them to work. So again, the patient needs support to make sure that they're getting their meds every single day. And so you don't even get to the cost of drugs until you overcome these other barriers. And that's where 340B comes in, is that the safety net provider can use the revenue to address these barriers that often arise before the cost of medication even becomes an issue. They help with case management, medication therapy management, as I previously mentioned, that they get them linked to care, they stay in care. And by keeping them on their medications, then you reduce viral loads to the point where they're non-infectious. So we're actually at a point where we could eradicate HIV in this country if everybody takes their medications and their viral loads are reduced to the point of being non-infectious. That's something we can do, but the problem is all these barriers, and people don't even know they have HIV, or if they do, they're not getting proper treatment. That's where the real problem is. And so if we just made a pass-through program where, 340B was just there to save money for patients, you're missing an opportunity to address the real problems that are fueling the HIV epidemic. And that's just one example, but I think you get my point, is that, you need holistic care to really be effective with patients. And 340B allows that. If you just focus the benefit on the cost of the drug, you're going to end up not really addressing these public health needs.
I don't think anyone in this room disagrees that holistic care is important for any patient, and that I would hope that this is something that any provider or the covered entities would provide. My one last question is regarding the state clearinghouse. Could you address that one more time? You seem to advocate for that. Is that correct?
I think so. Well, yes. I think everyone agrees it's a good idea. The manufacturers are already promoting the clearinghouse idea, but they're using their own private consultants. It's a part of this bipartisan bill, the PROTECT Act. So there's no reason that this couldn't be done at the state level. And we have actually an example of a state. The state of Oregon has done pretty much the clearinghouse model, and that's been in place for a long time. And so, yes, this would be a way of essentially addressing a problem that your state Medicaid agency is likely having right now, and that is protecting manufacturers from paying Medicaid rebates and giving 340B discounts on the same drug. And as I said, there are OIG and GAO reports that have documented that manufacturers are still being subject to these duplicate discounts and Medicaid managed care. So it's a problem that still needs a solution. And so a state could step in and, through a government contractor, establish a clearinghouse, which would then relieve the burden of the administrative burden on your state Medicaid agency.
Thank you. Thank you, Madam Chair.
Okay, we're back to Representative Landwehr, then Tarwater, and then we're going to have to cut it off. We've got someone online waiting to testify.
Thank you, Madam Chair. And it goes back to a comment that was made that you made about the uncompensated care. So actually, to simplify what's happening here, and it sounds like we have a few middle people in this, which maybe is costing us money, is this is more about the covered entity to have funds versus the federal government or the state government giving them money to cover non-compensated care. Would that be accurate?
Yes, that's exactly the point. It's an alternative to asking taxpayers to subsidize uncompensated care.
Yeah, and to clarify, this isn't taxpayer money. This is pharma money.
That's right.
Representative Tarwater.
Thank you, Madam Chair. To touch on what Senator Gossage was talking about earlier, the end user, the customer that actually qualifies for these discounts, that's evidently not being given all of the discounts, what overall percentage is actually passed on to the end user, the customer that deserves the break? Has there been any studies on that?
Well, it's going to vary by covered entity type, it's going to vary depending upon the part of the country that we're in. But if you just focus on federally qualified health centers, for example, they're required to have a sliding scale fee program where essentially patients pay according to their ability. So they look at what kind of income they have, what their assets are, and then they will get a reduction in their in what they have to pay based on essentially how impoverished they are. And you know, if they really have no resources, then they will end up paying nothing. And I, you know, hospitals and Ryan White clinics, they have similar policies. And so I think if you were to ask most covered entities, they would say, depending on the patient's financial status, they're getting the drugs either for free or for some minimum copay. But for those who have resources, either they're going to pay what you know, you and I would be charged, or there may be something in the middle. Maybe they get charged half the price that others would be charged. So it would be, again, sort of a sliding scale, similar to what the FQHCs are required to do.
So I guess a follow-up question on that would be if somebody had the means and was charged full price for the prescription, why is it on the manufacturer then to give a discount if there was no discount due?
Well, it goes back to the purpose of the 340B program. This is the drug companies doing their part to address the problem of uncompensated care in this country, because that burden would otherwise fall on taxpayers, or the patients just wouldn't get the care. And so, you know, it's a pretty unique approach. In a sense, it's kind of privatizing indigent care. But it's just essentially saying, look, pharmaceutical industry, you know, you get paid well by federal taxpayers because your drugs are often covered and reimbursed by the Medicaid program, by Medicare. So as a condition of participating in Medicaid and Medicare, we're just going to ask you to give these discounts, which is tied typically to the manufacturer's best price, extend those same discounts to these safety net providers because they're highly dependent on taxpayer support. And if you don't give them a break on the cost of the drug, that excess cost is going to get passed on to taxpayers one way or another, or onto the patient, and the patient can't pay for it, so then the patient doesn't get the drug. So, you know, it's basically looking towards the pharmaceutical industry to do their part in addressing the problem of uncompensated care in this country.
Okay, and then when a contract pharmacy is being used, do they pay the same amount? Like if there's a discount due to the customer, would they be billed the same amount, or does the hospital or the other entity make that decision as well?
Well, it's a ship-to, bill-to arrangement. So the drug is being bought by the covered entity, and that's always required. And it would be at a 340B discount. It gets shipped to the contract pharmacy. I think what you're raising is, what about, so how does the pharmacy know what to bill? Well, there's a contract that would be in place between the covered entity and the pharmacy that would address the issue of what the patient is billed. And typically, if the patient is uninsured or underinsured, the covered entity will use some of its 340B revenue to essentially pay the pharmacy whatever is not paid by the patient, because we want to make sure the patient doesn't walk away from the counter without the prescription filled. We want to make sure the patient can get their prescription filled no matter what their means are. So essentially the covered entity uses its 340B revenue to help offset the cost of the drug at the pharmacy counter. If the patient is insured, then the patient doesn't need help. The patient's already got insurance, and that revenue that the pharmacy receives from the third-party payer gets passed through back to the covered entity. And the covered entity then has that revenue that it can invest in indigent care for its patient population, or to basically use for the next pharmacy customer who can't pay for the drug. So that's sort of the model, but what the pharmacy's bill is dictated by the contract between the covered entity and the pharmacy, because the pharmacy essentially is acting as the agent of the covered entity.
Okay, thanks for that. And finally, Madam Chair, you had said that there was a fee for this testimony. Can you share with the council what that fee was, the total fees for this testimony?
Yeah, and I just want to clarify, they did not have any previous relationship at all. I reached out and asked. I actually got Mr. Von Osen's name through NCSL. And then I'm the one that reached out to the FQHCs. And what's your question, how much?
What were the total fees?
That was between them, that went directly to them. You can ask them this afternoon.
Okay, sir, what were your total fees for your testimony today?
You know, I have no problem sharing it, but, you know, I feel like I probably need to get approval from the party that is paying me just as a courtesy to them. I mean, why don't I talk to the Primary Care Association and get back to you? I just think as a courtesy, I really should ask them. But I can tell you that it's, you know, a greatly reduced amount, you know, compared to the typical fees that we charge. But there's a lot of time and effort that goes into planning these. So I do always request a modest fee to help offset those costs.
Okay, Madam Chair. I just was, I mean, this was a very one-sided presentation, and it was paid for by people that profit off of this program quite a bit and don't want to lose any control. So I would like to know what the total fees were for this eventually. Thank you.
I said.
No, I just want to clarify.
Okay, Representative Miller.
On that point, I think that's also privileged until the client authorizes it.
Yeah. Okay, we're gonna move on. I just hang on just a sec. Okay, I have a comment to make, but we've got to get to the next conferee, who is testifying virtually, and he is from Congressman Jake LaTurner's office. His name's Jake Middlebrooks. He's the legislative director. Mr. Middlebrooks, are you with us?
Yes, I'm here. Can you all hear me?
We can hear you. Welcome to committee.
Absolutely. Thank you for having me. I appreciate the opportunity. So I thought I'd give you all a brief overview. I know Bill mentioned the Protect 340B Act in his comments, but I thought I'd give you a brief overview from our perspective here at the federal level on that bill, what the impact of it would be, and then briefly touch on next steps for that legislation as well. So the Protect 340B Act has been introduced this Congress, and it's a response to concerns from safety net providers, especially those in rural areas who, as I'm sure you all know from the conversations you've been having today, have seen their benefits from the 340B drug discount program threatened by PBMs and insurers in recent years. And this situation where some of these PBMs have found ways to reduce the 340B savings that safety net providers are receiving through complex contracting procedures where they redirect 340B savings away from those safety net providers and are transforming this program that Congress initially intended to support vulnerable patients' access to life-saving medications into more of a subsidy for those third-party middlemen. And so what the bill would do, generally, at a high level, what it does is it prohibits health insurers and PBMs from discriminating against 340B providers or their contract pharmacies on the basis of their status as providers or pharmacies that dispense 340B drugs. And it prohibits them from doing that by imposing different rules or reimbursement terms that are imposed on other providers or pharmacies. So at a high level, that is the overarching goal of the legislation. And specifically, it would do that by prohibiting PBMs from treating 340B providers and their contract pharmacies differently from other similarly situated providers and pharmacies. And that applies in regards to their reimbursement policies, fees they're charging, including professional dispensing fees, participation in standard or preferred networks, and then audits and inventory management systems. It also prohibits PBMs from interfering in patients' choice to receive drugs from a 340B pharmacy, whether in person or by mail. And then also prohibits requiring 340B providers or pharmacies to identify 340B drugs other than for Medicaid purposes. Prohibits refusing to contract with 340B providers or contract pharmacies. And then, again, there's broad language about a prohibition on imposing quote unquote any other restrictions, conditions, practices, or policies that, as specified by the Secretary through rulemaking, interfere with the ability of a covered entity to maximize the value of discounts provided under Section 340B. So a lot of that would get worked out in rulemaking if this bill did pass. And then there also is language in there on the Department of Health and Human Services Secretary imposing civil monetary penalties for violations by PBMs of the Act. And then instructs HHS to contract with a neutral third party to serve as a clearinghouse for data needed to prevent duplicate discounts under Medicaid. And the contractor would collect data on 340B drugs reimbursed by Medicaid and state rebate data and ensure that those drugs are not included in states' Medicaid rebate requests. And so that is kind of essentially how the bill would work, the main provisions in it. And as Bill mentioned, I jumped on and heard some of his testimony. There is some bipartisan support for this. It's at about 50 co-sponsors right now across both sides of the aisle. And that number has been growing. I think at the same time, until this is passed, then it is largely something that's going to be determined at the state level. And even with the growing bipartisan support, I would not be incredibly optimistic about this legislation moving this Congress. It generally takes a while, as I'm sure you all know, for bills like this to pick up enough steam that they get passed and signed into law. And it seems like we're not quite there right now. That could always change depending on what the situation on the ground looks like. But that's where things stand right now at the federal level. And there are a number of other bills on 340B that are out there around maintaining status for 340B providers through COVID. But Protect 340B Act is kind of the primary piece of legislation that is out there right now, or at least where there has been the most conversation moving forward. So that is where most of the energy on this in this conversation has been directed to this date.
Thank you. Okay, we're going to move to questions. Senator Gossage.
Jake, thank you for being here. Just a really quick question. So to clarify, and let's talk about logistics. We're not talking about somebody who's on Medicaid and goes into one of these covered entities and they're going to fill a prescription. That's already taken care of currently. What we're talking about with this bill is if an individual who has private health insurance is going to come in to fill a prescription, and then they look at their list of pharmacies that are in network, they may find that this particular pharmacy is not in network for whatever reason. It doesn't preclude them from getting their prescription filled at that pharmacy, but they might pay a little higher price. So what we're saying is that PBMs or the manufacturer, their wherever they get their medication from. So say they have a group plan, the group plan has a PBM, they determine which pharmacies are in network. So what you would be saying is in this bill that they have to take every pharmacy, that they can't have a network anymore. They have to say, we're going to treat every pharmacy the same. Is that what I'm hearing?
Essentially, yeah. So essentially what it does is it just prohibits PBMs from, and again, it's that broad language at the start that prevents discrimination against 340B providers solely on their status as 340B providers. Theoretically, they could still have a network or make decisions on who is and is not able to be included, but they're not allowed to make that decision solely on the basis of whether or not someone is participating in 340B.
So if the state of Kansas says, as an employee of the state of Kansas, I were to take my card and go to a pharmacy that's not in network, but maybe they happen to be a 340B pharmacy, and I were to go there and not get that filled, or I don't go there and I go to one that's in the network. The rebate, PBM rebate, goes back to the state of Kansas currently. But what they're saying is, nope, we want to include the 340B pharmacies that also participate in the 340B program, that if I'm an individual in a private health insurance plan, I can go to one of those so that the rebate goes to the covered entity. Is that what I'm hearing? Because we're trying to get the rebate to the covered entity from people that are paying individual private health insurance. We're trying to make sure that they get that. So how is this affecting a rural hospital? And that's the end of my question. I know we're in a hurry. What does this have anything to do with a rural hospital?
So I think the problem right now is that you have rural hospitals where, let's say you have, I think the example you're talking about is someone who's an insured patient who is going to a 340B provider. So let's say they take heart medication that normally costs $100, and the PBM or insurer normally pays providers $100 for that heart medicine. And what that does is it allows the safety net provider to retain $30 in savings to help offset the cost of providing the medication. And so when this individual is, when the PBM is in essence discriminating against the 340B provider, again, solely on their status as a 340B provider by paying them only $70. Without the 340B savings, that rural provider can't use the benefit of the program to provide discounts to people who are coming in and seeking that heart medication for $100. So in essence, what it's doing is the PBM is taking the benefit away from the safety net provider because they're no longer, the dollars no longer make sense because they're getting the lower reimbursement level for that.
They want the reimbursement level on not only the 340B eligibles, but also for people on private health insurance. They want to be included in the network. But again, this would only be if the rural hospital had a pharmacy where I was getting it filled at that pharmacy, correct? Otherwise,
yes, that's correct.
How would it affect that? Okay, thank you. Thank you, Madam Chair.
Representative Miller.
Thank you, Madam Chair. Mr. Middlebrooks, if I called the congressman's office and asked for Jake, would I get you or the congressman?
You could get any number of people.
Well, that's good. My question is, and I apologize if you said this and I missed it, but of the 47 sponsors on this bill, is the congressman a co-sponsor?
Yes, sir. Congressman Turner is currently a co-sponsor.
Very good. Thank you, and thank him.
As well as Congressman Mann.
Yes, ma'am. That's correct.
Representative Wolfmore.
Thank you very much, Madam Chair. You know, we've talked a lot about script coverage, and I'm just looking at the original language of the 340B statute, and it says, reach more eligible patients and provide more comprehensive services. So I guess I'm asking you, this isn't just about helping pay for prescriptions. My understanding, at least, was it's about, for example, the safety net clinics to provide more services that otherwise wouldn't be covered. Maybe you could speak to that a little bit.
So I think it's tied into that as well because, and I think the 340B, the Protect 340B Act is specifically focused on the discrimination side of that, making sure that there's a level playing field. But I think what that does is when you have the 340B providers are able to operate on the same playing field as everyone else in terms of reimbursements or fees, that allows them additional discretion to provide those other services and reach more individuals.
Thank you, Madam Chair. Thank you.
Okay, Jake, thank you for joining us.
Absolutely. Thank you all for having me. I appreciate it.
And I keep thinking about your question, Senator Gossage. I think we'll hear more about how that impacts rural, but there's a couple, just two people, I think, on the committee that are rural. I guess within your question, there is an assumption that there's choice of which pharmacy to go to. Yeah, and so a rural hospital may draw from quite a number of miles away, and they want to go home and get their prescription filled at their local pharmacy. So, I mean, that's where we are much more restricted, is in the choice in the rural area. I will also add, after hearing the, I'm sorry? Well, you were talking about them going down a list of pharmacies and choosing which one they wanted to go to. Yeah. We don't have a choice.
No, I'm just saying I help people in rural areas all the time, and I live in the country. So I certainly understand. I'm 30 minutes away from anything. But no, all I'm saying is that they can still go to their, it's only if a rural hospital has a pharmacy that it would hurt the rural hospital. That was my point. Otherwise, how would it hurt the rural hospital?
We'll talk to the hospitals this afternoon.
Thank you.
They'll have a chance. Also, in your folder is a, oh, that's not what I want to show. Do we have Jerry Moran's? So Senator Moran had planned to be here today, and there was a committee for COVID relief meeting that was called for today. So he had to cancel, but there, do we have just toward the back? Do you see it? Okay, yes, it's the letter to Alex Azar at HHS, and that was that's the letter that Senator Moran signed on to, and that's in your folders too. Okay. So from the Attorney General's office, we have Stephen Anderson, and I can't find that testimony now. But thank you, sorry for the wait, but welcome to committee.
There it is. Okay, sorry about that. It's on now. Yes, need a taller microphone. So thank you for the opportunity to appear today and talk about the multi-state letter signed by Attorneys General. My name is Steve Anderson. I am the Medicaid Inspector General. Last year, Attorney General Derek Schmidt joined former Attorney General Xavier Becerra, now the U.S. Secretary for Health and Human Services, Connecticut Attorney General William Tong, and Nebraska Attorney General Doug Peterson in leading a bipartisan coalition of Attorneys General of 27 states in the District of Columbia, urging HHS to hold accountable drug manufacturers that are unlawfully refusing to provide discounts to federally qualified health centers, hospitals, and other providers that serve vulnerable patient populations through the 340B drug pricing program. The multi-state letter dated December 14, 2020, which is attached to my testimony, by the way, concerning the drug manufacturers' actions violated 340B pricing program requirements, was also signed by 27 other, or a total of 27 state attorneys general and the District of Columbia, and was addressed to Alex Azar, Secretary of HHS at the time. In the letter, the attorneys general argue that by withholding or threatening to withhold these critical discounts, drug manufacturers Eli Lilly and Company, AstraZeneca, Sanofi, Novartis Pharmaceuticals, Merck and Company, United Therapeutics, and others put low-income patients at risk of losing access to affordable medications while communities continue to battle the COVID-19 pandemic. HHS was urged to create a binding ADR process under which 340B health centers could seek to remedy some of the unlawful conduct by the drug companies. That ADR process has been put into effect by HHS. It is also noted in the letter that HHS has the authority to address the ongoing violations of 340B. Specifically, HHS has the authority to issue civil monetary penalties and to issue guidance articulating the statutory responsibilities of drug manufacturers. On December the 30th, 2020, Robert Charo, General Counsel of HHS, issued Advisory Opinion 2006 on contract pharmacies under the 340B program. In the opinion, it was concluded that covered entities under the 340B program are entitled to purchase covered outpatient drugs at no more than the 340B ceiling price, and manufacturers are required to offer covered outpatient drugs at no more than the 340B ceiling price, even if those covered entities use contract pharmacies to aid in distributing those drugs to their patients. Then on May 17, 2021, acting Health Resources and Service Administration Administrator Diana Espinoza sent letters to 6 pharmaceutical manufacturers outlining each manufacturer's violation of statutory 340B program requirements. The letter directed each manufacturer to submit a plan to come into compliance with the law. In the responses, the manufacturers refused to comply and did not provide such plans. Then on June 16, 2021, Delaware District Court Judge Leonard Stark issued an opinion that the advisory opinion from HHS differs from the 2010 HRSA guidance document and earlier guidance, as the advisory opinion is the first document in which HHS explicitly concluded that drug manufacturers are required by statute to provide 340B drugs to multiple contract pharmacies. On June 18th, 2 days later, HHS Office of General Counsel issued and noticed the withdrawal of the advisory opinion with an explanation it was done in the interest of avoiding confusion and unnecessary litigation. On September the 22nd, 2021, HRSA sent letters to each manufacturer alerting them, in light of their refusal to comply, the matter had been referred to the HHS Office of Inspector General in accordance with the 340B ceiling price and civil monetary penalties final rule. Thank you for your time. I'll be glad to answer questions.
Committee, do we have questions regarding this? Senator Miller, Representative Miller, you keep going back and forth.
Neither one is an insult.
Good.
Thank you, Madam Chair. Mr. Anderson, before our next meeting, would you ask the general if he has a position on legislation similar to Arkansas's HB 1881? I don't necessarily expect him to have a position, but if he does, I would like to hear it.
Yes, sir.
Thank you.
Representative Wolfmore.
Thank you. We had a little discussion earlier, and I just want to clarify something, I think. So the Rutledge decision, the Supreme Court decision, what the effect of that was they said that states do have the right to regulate PBMs. Is that correct?
I can't give an opinion on that.
Oh, okay.
Sorry.
Thank you.
Any further questions? Okay.
Thank you very much
for
for your
being
time.
here. You know, and I guess maybe I failed to talk about this morning, right when we got started, about how this committee came about. And those of you on House Appropriations already know this. But I brought a proviso to the budget, and that stated that the PBMs could not discriminate in their contracts. That got onto the budget. Well, let me back up. I was told that, you know, there were questions about whether or not we at the state level could regulate in any of the contracts. So it was put off to omnibus. At that time, we discovered that it was okay because of the Rutledge opinion. And the reason, the precedent that the Rutledge opinion places is that states can regulate the contracts. It's not the same, it was not on the same topic, but it was about state regulation. And that's the only thing that the proviso that I brought. Now, we've opened up a lot of other considerations this morning besides the discriminatory practice in the contracts, but we did, that's why it was allowed as a proviso onto the budget. It did pass both Appropriations Committee and the House. And then in budget negotiations with the Senate this had not been debated on the Senate side, and they were not supportive of adding it on as a proviso. But they did agree that we would have a committee that would get together and talk about the 340B issue and learn about it. So that's why we're all here today. We have our 1 o'clock conferee has had to cancel. So we do not need to, you do not need to be back until 1:15. So we're not chipping into your lunch hour at all. I'll see you back at 1:15. Oh, I'm sorry. We do have to be back at 1. What time were they scheduled? They were at 1:15. Is Aaron here? Okay, we'll be back at 1:15. Aaron will be here. He's not the one that canceled. Okay, we don't have everybody back, but we're going to get started. Got to try to stay on schedule. Okay. First up, we have pharmacists. On your agenda, it has Aaron Dunkel first. They're going to switch places, and first off, we'll have Sloan Freeman. Hi, welcome to committee.
Chair Concanon and members of the committee, thank you for allowing me to be here today. My name is Sloan Freeman, and I am a Kansas pharmacist. My husband and I own 12 pharmacies in rural Kansas, in small towns, and we provide contracted services for 8 340B entities. We provide contract pharmacy services for them. Today, I want to talk a little bit about the problems that pharmacy faces with the 340B program. First, I'd like to talk about the restrictions that some of the pharmaceutical companies and manufacturers are doing for access to drugs. There are multiple manufacturers that require the hospital entities to pick one contract pharmacy to run their 340B drugs out of. That poses a little bit of a situation because not everybody uses the same pharmacy all the time. For instance, we have 3 pharmacies that contract with one 340B entity within 45 miles of each other, but due to the restrictions, there's a town that has no 340B drugs when it comes to insulin and things like that. We do some charity care, so patients can get their insulin at a way cheaper price. The hospital is the one that approves the charity care for those patients, and then they get their insulin for under $20, and otherwise it would be $240 for that, if they didn't have insurance. And so we do provide some of that for our patients, but due to the restrictions, there's a whole town that doesn't get that anymore. So I just want to make you aware of that. We also have some language that is being tossed around by the pharmacy benefit managers. They are asking us to reverse our claims out of the insurance and then resubmit them to the insurance with a clarification code, with a code in there that says that this is a 340B qualified prescription. The problem is we don't qualify those. There's a third-party administrator that qualifies those based on data from the hospitals. So the patient goes in to see the doctors, the provider there. They write out a SOAP note, an encounter, and then they have ICD-10 codes that get submitted, and then they match them up with the drug. So we have no control over any of that, but the PBMs want us to tell them when it's a 340B item and when it's not. Some of the problems with that is it's a huge administrative burden because now I have to go in every single day and look at all my claims and see, is it qualified, is it not qualified? And it can qualify up to 30 days because sometimes those providers don't get their notes in right on time because they're busy doing other things. So now I have to look at 30 days worth of data and see if it qualifies or if it doesn't qualify. Also, when I go and reverse it out of my system, it also reverses out a 340B. So then I have to hope that it qualifies again because I just told the PBM that it qualified. So that's a huge problem for us to have to navigate, and I mean, it's going to take a lot of administrative burden on our end and also on the hospital end because they're going to have to help us see what should qualify and what shouldn't qualify, and so that some of that is an issue if that is kind of coming down the pipe. Also, we're just trying to keep rural healthcare intact. The 340B program does give hospitals some money, but those hospitals are in need of doctors. And, it's really hard to find a doctor to come out to Western Kansas. And so you're going to have to pay them more. Well, right now, they're not able to pay them more. And with the 340B program, we're hoping that, we can keep a doctor in town and save our hospitals so that we all can have access to good health care and not have to go several miles to go find a hospital or a clinic. So those are mainly the issues that we have as a pharmacy. I like the charity care part of it that we provide because it makes me happy that I can provide life-saving medications at a lower cost to people, that I wouldn't necessarily be able to provide. And healthcare costs are rising, and it's really difficult for me to look at a patient and say, I'm sorry, that's going to be $300, and if you can't get it, then you might die. And so with 340B, I think that it is really good to have the charity care piece of it and make sure that we're taking care of our patients in rural Kansas and throughout the state. So, thank you.
Thank you. Can you, can we hold questions till after both of you? Okay. Okay. Next up is Aaron Dunkel. From Kansas Pharmacists Association. Welcome to committee.
Thank you, Madam Chair and committee, for the opportunity to come and speak a little bit this morning, or this afternoon now. I listened to the morning session remotely and just obviously heard what Dr. Freeman said, so my comments will be relatively brief because I think you've heard a vast majority of this already. Really, as we were looking through, and to come at it from a pharmacy perspective, Dr. Freeman just kind of went through the big pieces. What we've seen, I know one of the questions that was posed to us when we were contemplating coming up and doing testimony was, what are some of the changes that have taken place and what are the impacts of those changes? And we want to be completely transparent in the fact that the things we're going to talk about aren't things that are being done across the board right now. They're things that are being done by certain members in this industry. And so what our fear is, obviously, is that if things are successful and they get, depending on your determination or your definition of successful, and they get rolled out across the entire spectrum. The three things that we've really seen being implemented are that some PBMs have changed requirements for their contract pharmacies to include determination of 340B status for prescription at the point of dispensing. In the age of data, that sounds reasonable. For those that deal with data on a daily basis, you understand that's probably not as reasonable as it might sound on its face. Unfortunately, most of the data used to make the determinations is currently not available to pharmacies at the point of dispensing. And that puts a huge burden, as Dr. Freeman was talking about, on the pharmacy staff or on hospital staff to do things that right now are just not technologically available to them. So it's either a huge investment from a technology perspective or it's a huge investment from a human resource perspective to even attempt to make that happen. The second thing we've seen is a number of PBMs have forwarded contracts over the last few years that would actually reduce reimbursement for qualified prescriptions. This is often referred to as discriminatory reimbursement. I know you've heard a couple of folks talk about discriminatory reimbursement this morning, so I won't go through all the details on it. But again, this is money that really is being diverted away from the covered entity under current law and being retained or withheld at the PBM level. And of course, our big concern is that it's really wasn't the intent of the program. That's not where the dollars should be retained. They really should be retained at the covered entity and provide those services that they were intended to provide. And then the third and final change we've seen has been several drug manufacturers limiting the number of contract pharmacies that a covered entity can engage with. In this case, the manufacturer will not make the 340B pricing available to covered entities for more than a specific number of contracted pharmacies, and usually that number in a lot of the contracts we've seen is 1. And while that might help meet the end of the manufacturers, in the real world, that change reduces patient access. As Dr. Freeman was mentioning, when you're in a situation where you're in a rural community and you have a hospital or an FQHC that provide services to folks from several communities within a geographic catchment. And they really want to be able to have that pharmacy or that medication available locally to those folks. That's how that is accomplished, is through these contract pharmacies. And so, of course, our big concern with that is not necessarily that there's not an alternative on how they currently do it within the program, but under the current law and the way things are structured, that really the only way to provide that service at the local level is through those contract pharmacies. So we'd hate to see that go away. But with that, you got a lot people that have a lot more information than I do to follow up behind me, so I will relinquish the mic.
Okay, thanks, Aaron. I think we'll just, are there any questions for pharmacy? Oh, Senator Pittman.
Thank you. Thank you both, Dr. Freeman and Aaron Dunkel. I appreciate your testimony here. What would your ask be of the state at this juncture from a pharmacist and as an access to, you guys are on the ground as the pharmacists, small town pharmacies are coming out. They're out there in the field. They're interacting with the folks doing this, as well as the hospitals out there. What is it that you want to not be at the whim of these programs that are limiting the access to this program from a pharmacy point of view? I see the description of the problems and it's pretty articulate, but what's your ask?
I think from a state perspective, and we'll have to break it into two pieces. I think from a state perspective, we've seen a number of states that have put law in place that have basically said you can't do the discriminatory reimbursement. So whether it's a 340B claim or whether it's a commercial claim, unless it qualifies for charity care, it's processed basically the same. That's really, and we've seen, like I said, we've seen that. We know that under some other reviews that has seemed to be something that is legitimate under the state law. The component that we have around the determination of 340B on the spot, there's a question of that. I'm not sure exactly what our ask is. I think that was more of this is something we're seeing in the market, and it's concerning. And then really the deal with pharmaceutical manufacturers, our take on that, at least from an association perspective, is that probably is something that would either need a federal fix, whether that be policy or law, but it's really something that would be really difficult to do at the state level.
Thank you so much for that.
Senator Miller.
What? What'd you call me?
Representative Miller.
Thank you. Thank you, Madam Chair. For Ms. Freeman, please. Do you know why the PBMs want you to say which ones are 340B claims when in fact you're not the one that is the arbiter of that? Do they use that somehow as an argument for payment or whatever? Why are they asking you to do that?
Currently, there's one PBM that wants to pay us less for it, and I believe the other ones are just collecting data at this point to see what qualifies as 340B and what doesn't. Eventually, I would say it's to match up the rebates to see, because they get rebates on their end, and then if it qualifies as 340B, then that becomes a rebate on the 340B end and not on the PBM end. And so I believe it's just to match up the rebates. But like I said, I have no way of qualifying these. So.
Yeah, it seems like they're just using it as a device to pay less, but you're not the arbiter of the. So are you inclined to say you are or are not, or one of those claims is or is not?
I'm contractually obligated, yes, at this point.
And did I hear you say you and your husband lose money in 14 different places in Kansas?
Just 12.
Oh. And if I may, back to the similar question of Senator. Yeah, I know. Mr. Dunkel, did you sit through this morning's testimony?
Representative, I kind of sat through it off and on. We had some other issues going on at
the one fellow was pretty partial to this Arkansas bill Are you familiar with that bill?
Not specifically, I'd have to go back and review it.
Do you know enough about it to tell me whether or not you're partial to it? Or whether it would address your concerns?
I'd tell you the truth without going back and reviewing.
Okay,
I've
well, I'd be
read so many of those.
I'd be
I'm not
interested
sure.
in knowing if what you have a problem with would be addressed by that bill, or if your problem goes beyond that. Thank you, Madam Chair.
Senator Gossage.
Thank you, Madam Chair. We were told in a chart from the Century Data Systems that the only eligibility could be determined by the covered entity. In this case, wouldn't the pharmacy be the covered entity?
You want to answer that? Senator, she's a lot better.
The covered entity is like an FQHC or hospital or Indian Health Reservation. We are just a contract pharmacy, so we provide pharmacy services, but we don't have any jurisdiction on what qualifies and what does not. They match them up by the provider's notes, and so yes, in theory, the covered entity is the one that qualifies it. They usually have what's called a third-party administrator that matches up their data and our data, and then they do it because the hospital doesn't really see our prescription data, and we don't see their notes. So this is kind of an in-between person that matches them both up, and then based on the qualifications, either qualifies it or does not.
So I understand that this is an issue for you, especially a time-consuming issue, but I don't see that that's something that the legislature could address. However, when you're talking about the TPA, the third-party administrator, so that it sounds like that's something that maybe you guys could get together to discuss with them of how this is an issue, in that they make the determination if it's eligible, if this medication is eligible, if the person is eligible. Seems to me they can just send that to you when they send the prescription.
They don't send the prescription. They get our data after. It's not in our computer system. So pharmacy works a little bit different than like a doctor's office. Ours is an immediate adjudication. So I know in 5 seconds what your copay is and if it's covered and not. Then after the fact, they get our data at like midnight for the day. And so they're not in our system. They have a data feed to us. So
but somebody had to prescribe it, right?
Yes, the doctor did.
Right.
So there's 3 entities, basically. There's the hospital, the TPA, and then the pharmacy, and we both feed our data in there at midnight every night, and then they go through and match it up.
Okay, thank you.
Sloan, did I miss it, or did you say where you're from?
I live near Sharon, Kansas. We have pharmacies down in central, southwest Kansas.
Okay, thanks. Further questions? Representative Tarwater.
Thanks. I have a kind of confused. So if you're participating in the program and you're selling prescriptions to people, not knowing if they qualify for the program, how do you know what to charge them? Or do you just charge everybody the same thing, and then there's a spread there that you guys can divide up later if it becomes that it's a qualifying purchase?
There's 2 components of 340B. One is run it through insurance, and then it qualifies later. And then the hospital, that's kind of the, for lack of a better word, money-making part to help keep the hospitals open. And then there's also the charity care part of it. If we do charity care, we do hold on to the medication until it qualifies. So I go in the next day and I say, okay, that one did qualify because they went and saw the doctor, so now I can give it to them at the cheaper price. But most of it is just insurance. So it doesn't necessarily matter because we charge them their copay on that end of it.
So when there's a contracted pharmacy, all of that money goes to the charitable programs, not to the end user or the insurer. The person qualifies.
I'm not understanding your question, I'm sorry.
So there's a deep discount given for people that qualify for the program, but if you don't know to give them the dollars right up front, they don't ever get them. And so anybody going through a contracted pharmacy would therefore not get the benefit of the discount, nor would their insurer. but that all just goes into a kitty to help uninsured individuals.
I'm not sure how the hospital uses their money
you.
that they get.
Thank you.
Representative Wolfmore.
Thank you. Maybe I just want to follow up on that because I think, but correct me, I think what you're asking is not only does the hospital, the safety net clinic benefit by this, but does the patient actually, they go in to get their insulin, they can't afford it, they get it at a cheaper price. So the patient actually does benefit from this, not just the covered entity that's doing it. The patient is, and many, many times, gets the benefit of a lower medication because of this program. Is correct?
Yes. If they qualify for charity care, which the hospital has their rules for qualifying for charity care, then yes, they get a deep discount on the medication.
Because there's sort of two aspects of this program. One is to make sure that these entities can offer other kinds of care that may not be covered, but they're underinsured, uninsured. But then there's also the benefit of giving the patient a lower or no cost on some medication they can't afford, correct? Okay, thank you very much. Thank you, Madam.
So there's a difference between 340B and charity care as far as, I mean, some of them are the same, but
It all
not
runs,
the same criteria?
It all runs through the same program. It all runs through the TPA, and they all qualify the same. If the hospital says that this person qualifies for charity care, then we run it as a charity care case. Otherwise, it is through their insurance. So there's kind of two avenues of that.
Representative Tarwater.
Okay, so I think that kind of made it clear as mud to me. So it was, so you can qualify. You do qualify people.
We do not. The hospital does based on their charity care rules
But you
that they
do
have.
know when you sell them a discounted drug, you are able to know that.
The next day, yes, I go into the.
But you charged them for it today. You said you're not going to know for it till tomorrow. They take the drug and then they come back the next day and pay?
They don't take the drug until I know that it's qualified, because otherwise I would lose $240 on that prescription.
Okay.
So.
Okay. Got it. Thank
Yeah.
you. That makes a little more sense. Thanks. So the bottom line is that you do know. At the end of the day two, you'll know who qualifies and who doesn't, and you could track that.
Sometimes, yes.
Okay, thank you.
Sometimes if the doctor's office does not get their notes in, then it takes up to 30 days to qualify.
Senator Gossage.
Thank you. So as Representative Concanon said, those are two separate programs. The 340B and the charitable program for the insulin are two different programs. Even though you see them funneled through the same TPA, that is not part of the 340B program, correct?
I mean, it is. They all have the same, I guess, they all get qualified the same.
They get qualified the same, but I'm just saying that the charitable care toward the insulin is a separate program than the 340B, even though it's often the same people, the eligibility is the same, et cetera.
I'm not really sure how to answer.
Okay, that's all right.
I mean, like in our contract, it's one contract with the entity.
With the
so we don't
hospital.
have two different contracts for that. So
thank you. And I just have one more question for you, if I may, and that is, and thank you very much for your answer. So I understood you to say that what the expectation is from the pharmacy is that whether it's a 340B medication or whether it's a medication that doesn't qualify under the program, you would like for the reimbursement to be identical.
The reimbursement for the non-charity care, so if it's one that's processed through as a regular insurance claim, that reimbursement, I mean, the intention of the program, the way it's been ran up to this point, has always been that those reimbursements are identical.
And that's part of the law, the original 340B law?
It's the way that it's been ran out. It's
the way it's been run
right.
Historically.
Yeah.
Thank you.
Representative Miller.
Thank you, Madam Chair. This is a novice question. I'm a novice on all this, but this would be a good time to ask the pharmacist. And I had this question this morning, but Representative Tarwater kind of drew a line under it, because this morning we were talking about discounts, he used the term deep discount. Can we get an idea of what kind of discounts we're talking? And I assume it varies from drug to drug, but are we talking about 20% off, 80% off, 100% off?
To tell you the truth, I hate to push questions off, but that might be a better question for some of the folks later, because the pharmacies actually don't deal.
Whoever, I am curious, I imagine this is very meaningful to the people who are affected. Thank you.
Yeah, thank you. Any other questions? Okay, thank you. Got too many agendas in front of me. Okay, the pharmacy benefit managers, neither one of them are here. They had some travel issues and couldn't be here. So next up, we have Carolyn Ha. She was going to join us virtually. While we're waiting for her, I might mention that staff printed off the KLRD resource page, the items that are on that, and passed them out to everyone during lunch. So you have those.
Could I ask, are we going to arrange for the PBM people to be here? They are critical to this conversation.
Well, we invited them, and these are the.
I know they had travel problems now, but are we going to continue?
Yeah.
I would certainly love to ask them a couple of questions.
We will continue to try to have them.
I appreciate
either,
that. Thank you.
Here or virtual.
Thank you.
Yeah, I think it's important to hear from everybody.
Yeah,
to hear from
virtual's just fine.
Okay.
Thank you.
Mm-hmm. Do we have Carolyn?
Hi, can you guys hear me okay?
You know, we can hear you, but not very well. It's real far away. Can you?
Okay, let me try to speak up. Can you guys hear me okay?
Not yet.
Okay, I'm turned up as loud as I can. Can you hear me?
Yeah, I think it's on our end.
Oh, okay. My apologies.
No, our apology. Okay, try again.
Okay, can you hear me better?
Yes, we hear you great.
Awesome.
Welcome to the committee.
Thank you so much. Good afternoon, everyone, and thank you to Madam Chair Concannon for the invitation to be here today, and to the special committee for holding this important session. I'm Carolyn Ha. I'm a senior director in Pharma's Policy and Research Department, and we really appreciate the opportunity to be able to provide the manufacturer perspective on this very important federal prescription drug program. And hopefully I can help answer some of the questions that I know have been raised this morning from a manufacturer's perspective. So just by way of introduction, we are the Pharmaceutical Research and Manufacturers of America. We are a trade advocacy organization based here in Washington, D.C., and we represent the nation's leading innovative biopharmaceutical research companies who are devoted to discovering and developing medicines that enable patients to live longer, healthier, and more productive lives. Since 2000, our member companies have invested more than $1 trillion in the search for new treatments and cures, including over $90 billion in 2020 alone. And with the introduction of new treatments and vaccines, pharma member companies are also playing an important role in the continued fight against the COVID-19 virus. And we also wanted to take a moment to thank all of our fellow panelists and frontline providers who have been taking such good care of patients during these challenging times as well. In 2020, manufacturers provided rebates, discounts, and other price concessions that totaled $187 billion in 2020. So I'd like to start by providing our perspective on the 340B program when it was created in 1992, as we have been a supporter of the program and we have been written into the program since the start. So Congress created the 340B program in 1992, about 2 years after the Medicaid program went into law in 1990, and it was really to assist those federal grantees, those health centers, and safety net hospitals that were inadvertently no longer able to obtain the voluntary discounts from manufacturers after the enactment of the best price provision due to the new Medicaid law. So to assist those healthcare facilities, Congress made certain qualifying hospitals and safety net clinics eligible for these steep discounts that you keep hearing about to help vulnerable patients access medicines at these safety net hospitals and certain clinics. So I think there was a question in the prior session about an estimate of the discounts. That's a great question. They are set by a statutory formula, but some public estimates have them anywhere between 50% or more, and depending on the drug, and again, the statutory rules, it can go down to a penny. So there are certain drugs, again, depending on the formula, that are penny priced. So entities are actually able to purchase these drugs for just a penny. Not all the drugs, obviously, because that would almost be like a 99% or more discount, but on average, guesstimate about 50% discount or more on these medications. And we're happy to provide additional follow-up information if you're interested in that after the hearing. So again, Congress really wanted to reinstate these voluntary discounts, which manufacturers have been paying since 1992. Unfortunately, what we're seeing now, almost 30 years later, is that this was a small program when it started out. So it's really historically been run with not a lot of rules that are written into the statute of the 340B law. This program has really been run on a series of agency guidances. It's overseen by HRSA, the Health Resource Services Administration. It's a pretty small, not very well-known agency within kind of this very huge HHS agency. And so really it's been run on kind of these very loose program rules, which, unfortunately, many of the participants have been able to use to their advantage. And unfortunately, what we're seeing is that this lack of transparency of how the discounts are being used, how patients are being qualified. You're hearing about this muddy process of, was it a 340B patient? Was it not a 340B patient? Everybody's kind of been swimming around in kind of this muddy pool of the 340B program, very loose rules. And unfortunately, who's kind of getting left out is the patient and their ability to better afford their medication. So, what we've seen over the past 30 years is evolution of the program that is now primarily financially benefiting these larger, very savvy health systems, these for-profit chain pharmacies, and other middlemen such as pharmacy benefit managers. And again, not the patients that rely on the safety net. And unfortunately, we're worried about the sustainability of the program for the small rural providers and the health clinics, such as Ms. Freeman's, as she's doing her work in the more rural areas. So you guys have probably heard a mouthful on the 340B program today, but not a lot of people are probably familiar with this program. I think a lot of folks are surprised when they learn about how large the program is and the breadth of the program. So to put the program into context, 340B is now the second largest federal prescription drug program, only behind Medicare Part D as in dog, which is the prescription drug benefit for seniors. So 340B is even larger than Medicare Part B. It's larger than Medicaid and any of the military prescription drug programs through the VA, the DoD, or TRICARE. So, across the country today, almost half, just a little over 40% of all hospitals are now participating, and it's hospitals of all sizes. So you have your rural referral centers, you have those, sole community hospitals in the rural areas, but you also have large hospitals in metropolitan areas that are also participating in the 340B program. All hospitals do have to be nonprofit to participate in 340B. And I think this number was also shared earlier this morning, but the total sales through the 340B program increased by 27% just in 1 year. So it is now at about $40 billion. It was $38 billion in 2020. And, this is all manufacturer funded discounts. So these are discounts that biopharmaceutical companies continue to pay out tens of billions of dollars every year to these hospitals and the clinics. But again, our concern is that these tens of billions of dollars are not always making their way to helping patients better afford their medicines. So I want to spend a little bit of time on this diagram just to show and maybe walk through the purchase and payment flow and how manufacturers interact with PBMs and pharmacies, and then what our involvement is in the 340B program, if it kind of helps explain. So you'll notice here that manufacturers have separate pathways in which we interface with different aspects of the supply chain. So on the left-hand side here is the rebate model, which more folks are probably familiar with. This is typically how your commercial and Part D programs work. So manufacturers will typically pay a PBM a retrospective rebate or fees that are after the fact, right? So these are usually after units have been dispensed. Usually they're trued up at the end of the month or at the end of the quarter, and depending on the volume that was dispensed on a particular drug, the PBM will invoice the manufacturer and a rebate is paid on that. I think most people are clear on that. Then over here on the right-hand side, what you see is the manufacturer's interaction with the covered entity. And in 340B, as you've heard, these are upfront prospective discounts that are paid to, that are provided to the covered entity. So the covered entity is able to purchase medications from the manufacturer on these 340B outpatient drugs, like we said, at a pretty significant discount. And really, in theory, what it's allowing them to do, as you've already heard, is be able to have a little bit of cushion, right? Have that spread because they're now able to acquire at a lower rate than what a typical purchaser would be able to purchase at. But they're also billing the health plan or the PBM for other claims. So it's the commercial claims, it's the other insurance, and there's going to be that spread. And that spread is what hospitals and health clinics rely on to be able to provide those services that they talked about. But more importantly, in addition to the screenings and the immunizations and the MTMs, really a portion of that spread was intended, again, to help offset the cost of the medications and reduce the cost sharing for the patient. So, that's pretty much where the manufacturer's role and our interactions end. We have two parallel but kind of distinct pathways in how we work with the PBMs and then how manufacturers work with the covered entities. Then what you see here at the bottom is kind of a bidirectional relationship, which I'm kind of just sharing for illustrative purposes. Again, we don't have insight into the contractual terms or what's going on, but generally, you've noticed that covered entities do need to rely on some of these external pharmacies to be their contract pharmacy. So they're going to be, paying the pharmacy some sort of an administrative or dispensing fee. The pharmacy is also able to partake in a little bit of that kind of profit sharing, if you will, that spread that the covered entity is retaining for being a contract pharmacy. They're now in a profit sharing relationship. And then, like I said before, the covered entity is still billing the PBM for other types of claims, commercial insurance and Medicare Part D. So, again, as you can see, manufacturers have our own relationship, and then there's a contractual relationship with financial flows between the PBMs and the covered entities. And I do want to maybe stress here that there's a lot of interest in this program. I think it's because of how much it's grown, but there are questions again as to whether or not patients are better off today in terms of being able to afford their medications. That's what the 340B program was put in place for. There are now questions about kind of where those discounts are going or how they're being used. And we don't want to, paint broad, strokes to say everyone's a bad actor, everyone's a good actor. But again, there are a lot of questions. And I think the tussle and the tension is really, in the 340B dollars, those profits, how they're being used. And, unfortunately, again, the patient is kind of being left out of this conversation when there's a lot of this infighting, with kind of the dollars, like I said, and where they're going and how they're being used. So now I'm going to switch gears a little bit and maybe talk about contract pharmacies, which you've heard a little bit about already this morning. I do want to stress here, again, there are 15 types of those covered entities that you heard about. Those are the 15 types that are actually written into the 340B law of who's eligible to receive the discounts, who's able to purchase at 340B price. Contract pharmacies were born out of agency guidance. They do not carry the force and effect of law. And they were really started a couple years after the 340B program was started because back in the day, a lot of these covered entities are small, community clinics. They did not have the capability to have their own pharmacy on site. They didn't have the staffing, they couldn't hire a pharmacist, they didn't want to apply for pharmacy license, and probably, most importantly, they did not have the physical space, the capacity to house this inventory of drugs. And so really, HRSA recognized this and said, all right, covered entities, you're now able to contract out. You're able to designate a location, a pharmacy, to help dispense these medications on behalf of the covered entity for the 340B patients that the covered entity just saw. And back in the day, I think these were, a lot closer relationships. It would be a covered entity, that knew their local pharmacy around the corner, typically a mom and pop shop. And, they would enter into this one-to-one arrangement. So, the health center on Oak Street now has one contract pharmacy relationship with Bob's Pharmacy. And that is how it was up until 2010, when HRSA decided to change its guidance and basically allowed covered entities, the health centers, the hospitals, anyone who's a covered entity could now enter into multiple contract pharmacy arrangements. Did not matter if you had your own in-house pharmacy or not, you could enter into as many contract pharmacy arrangements as you wanted. And what we've seen is this explosion of very expansive contract pharmacy networks, very sophisticated networks that, again, are really benefiting the larger health systems and these for-profit pharmacies and their affiliated pharmacy benefit managers because of the profit potential that could be made. And again, patients are getting left out of the conversation. So what you see here is a depiction of the exponential growth in contract pharmacy relationships since that 2010 guidance went into place. We've seen a 4,000% increase in the number of arrangements. Today, there are nearly 30,000 distinct pharmacy locations across the country that participate as a contract pharmacy. And like I said, you can have multiple arrangements. So that's why you're seeing the kind of over 110 and growing as we speak, a number of arrangements that are being formed. And, I do want to stress here that growth is not necessarily, inherently viewed as a bad thing, right? The concern with the growth is that it's not in line with the patients that are, being helped by this program and patients who are better able to afford their medications. I think we've certainly heard a lot about the expansion of services, and that's great that the hospitals and health centers have been able to take the savings from 340B to expand their services. But there's a second part to the 340B program, which is essentially to help patients offset the cost of their medications, and we're not seeing that. And as you've heard with some of the kind of confusion around whether or not patients are able to get that discount today at the pharmacy counter, there are unfortunately some difficulties with identifying patients, and so patients that show up at the pharmacy counter today are not always able to benefit from the 340B discount. And yet we have 30,000 pharmacy locations, contract pharmacy locations around the country. It's gone up 4,000%. So something's not adding up. And, we have study after study from these independent government agencies that are showing that, unfortunately, these 340B discounts are not always passed on to uninsured patients at the contract pharmacy. So again, that's, I think, where a lot of our concern is coming from. And, just for a little bit of local flavor, sometimes we get questions on how many contract pharmacy locations are in a state. So in Kansas overall, there are about 500 contract pharmacies that are associated or affiliated with the covered entities. About 70% of those pharmacies are located within the state of Kansas, and then you have about 30% that are outside of the state of Kansas. And sometimes we get questions on, well, how can that be? Sometimes there are contract pharmacies that are, around border towns or just across the river, just out of convenience and for access purposes. Other times, as I think you'll hear about as I get into this a little bit more. These are part of those vast, expansive networks that have been set up by PBM affiliated specialty pharmacies or mail order pharmacies. So it's not uncommon, for one hospital to have, dozens, sometimes upwards of 400 different contract pharmacy arrangements. And these contract pharmacies are located thousands of miles away, sometimes in these mail order facilities. So, part of that 142 that you see outside of Kansas, could be hundreds of miles away. All right, so what we're seeing more and more, and again, this 340B started off as a small program, was really meant to help, safety net clinics, has now really become dominated by a lot of for-profit companies. So 3/4 of all the contract pharmacies that are participating are chain pharmacies. You'll see they're really dominated by, just a couple of household names. And probably what's of more growing concern, due to a lot of the vertical integration that we're also seeing within the marketplace and consolidation, is that almost 1 in 5 of these arrangements are between covered entities and then 3 of the largest PBM-owned specialty and their own mail order pharmacies. So again, for a participant in the program that was not originally written into the 340B law, contract pharmacies that guidance in 2010 has certainly given the for-profit and vertically integrated entities a very large role in the program, even though they were not contemplated by Congress when the law was written. So, contract pharmacies have found that 340B can present pretty significant profit opportunities. So you see here that research has been done that shows the margin that can be made, again, because of those significant discounts and the spread that a 340B medicine can present up to a 72% margin, through a contract pharmacy compared to, a non-340B medicine that's dispensed at a community pharmacy. And again, as we talk about the for-profit nature of this program, more than half of these profits are now retained in just 4 pharmacy companies, and many of them are publicly traded. And it's not just the contract pharmacies themselves, it's all the other affiliates that are tied to 340B. So whether they're a wholesaler, a third-party administrator, as we talked about, a PBM, they're all able to generate profit from this program. 9 out of 20 are on the Fortune 500 list. And again, underscoring that there is no evidence that 340B discounts are helping patients better afford and access the medicines that they need. So I think it is a little unfortunate that our PBM partners were not able to be here today, but I did also want to highlight, again, just the greater consolidation and vertical integration and really concerns for, patient choice and steering, even within the 340B supply chain. So you'll see here, as I said, that the specialty and mail order pharmacies that are owned by PBMs are really representing the fastest growing share of the 340B market. As I mentioned before, those profits retained by contract pharmacies are concentrated in just 4 companies. And many of those companies are already affiliated with their own health plan, PBM, or TPA, or third-party service, 340B services firm. So they've really got it figured out. They've kind of got the market cornered and have everything under the same umbrella of common ownership. Even though you see this number of 30,000, it's a very vast network, but it's really just kind of concentrated in just a few companies. And that, really raises a lot of anti-competitive concerns, concerns about patient choice and whether or not, the way that this is set up is influencing utilization and, where patients may be forced to go get their medications if the, PBM also owns their own contract pharmacy. So just wanted to, share some of the landscape of what we're seeing in the marketplace. These are discounts that we've already provided, and we don't necessarily have control once the upfront discount is already provided to the covered entity, how else the money flows through the system. We just want to make sure that at the end of the day, patients are hopefully benefiting from this program. So just to wrap, I just wanted to reiterate and thank the committee for having us here today. Pharma and our member companies have long supported the 340B program and its original mission and the critical safety net role that it was really intended to play in our nation's healthcare system. Again, the industry entirely funds this federal drug program, not the government, not taxpayers, and we unfortunately have very little line of sight into how our contributions are making their way to help patients. We've seen report after report that shows these savings are not necessarily being used in the right way to help patients. We've talked about how middlemen and other for-profit companies are really using these savings to boost their bottom lines instead. These are savings that were intended to help needy patients afford their medications. As an industry, we are advocating for hopefully more meaningful improvements that can be made to help ensure that those discounts are making their way more directly to patients, and hold covered entities and others accountable, and PBMs accountable for how they're using those 340B discounts. And so we think that, some steps can be taken to increase transparency, to help ensure that greater accountability and tracking of the 340B claims and discounts. So we know that it's a 340B patient at the end of the line that is getting that discount. Again, I do want to reiterate, we heard some comments that were made about perhaps, the industry going to war against certain entities in the program. And, that really couldn't be further from the truth. The pharmaceutical industry is doing more than our fair share to help indigent patients afford their medicines. Today, there are over 600 manufacturers that are participating in the 340B program. And so respectfully, we just wanted to say that there's no war coming from industry. We continue to support the program and are honoring the 340B discounts to the covered entities. I think, again, unfortunately, what you're seeing is a lot of infighting over those profits, to whom it benefits. And, we're just keeping our eye on the patient, and we want to be able to help in any way we can with prescription affordability. So with that, I will, close and happy to take questions.
Okay, thank you. I think I'll start. I have a question referring back to page 11 on your slides. And, you're talking about all of the for-profit, and there's no assurity that the discounts or the savings is reaching the patient. The other thing I noticed here is that none of the 340B entities are listed here either. And it's my understanding that they have to be nonprofit to qualify.
Yes, that's a great question. Yeah. Yep. So, yes. So according to who is eligible as a covered entity in the 340B statute, who is eligible to purchase from manufacturers for 340B medications at the 340B ceiling price, those are the covered entities, and there are requirements that they are nonprofit entities. So it's the hospitals. There's like 4 or 5 different types of hospitals. You must be a nonprofit hospital in order to participate in 340B. This kind of for-profit portion of the program, they came on as contract pharmacies, so they are not listed in the 340B statute as being eligible to purchase at 340B price. They're just able to be a partner with those hospitals, and so they're able to share a little bit in any of the savings that the hospital is able to retain. But you're absolutely right. These companies are actually not eligible to purchase at the 340B price from manufacturers.
Okay, thank you. Senator Pittman.
Thank you, Mr. Chair, and thank you. What's that? Did I say Madam Chair? I'm sorry if I said Mr. I apologize. I appreciate that, Mrs. Ha. There's one thing I'd be aligned on is that looking at programs that will keep this in place, I would absolutely be in agreement with you in terms of making it continue to help my constituents in my area that definitely take advantage of some of these discounts. I do believe some of these discounts are actually reaching them, and they feel it on their bottom line when they can go in and buy some of these discount drugs. And we appreciate the manufacturers and all the great innovation they do, I'm sure. But I will say that it seems it's falling on deaf ears here, and I'll just let you know where I'm coming from. When we talk about choice in these drugs, and there's monopolies inside of this country on the drugs that some of my constituents have to take by certain pharmaceutical companies, and I don't find that to be a very solid argument. And actually, I find it to be a little bit disingenuous to talk about the ability to have choice about which drugs I can take and where I can get them for my indigent citizens who often don't have a choice about whether they can even get around to 2 different locations. So the fact is, if you look around, we have higher prices on most pharmaceuticals by nearly 56% compared to other nations out there. And we have folks going across the border just to get a discount on drug prices. And when I look out there, I see that the industry is growing from anywhere from 400 to 700 billion today out to estimates of a $1 trillion to $1.5 trillion in a few years. And we're talking about a very small slice here. We hear about 37% increase in sales, largely due to cost increase and the volume of folks that are using these things. I don't see that the pharmaceutical manufacturers need to get so heavily involved in this, and I do see the PBMs needing to have some reformation here. But I don't think that the arguments that you've just laid out are very compelling to me as to this program having been abused by these different hospital entities to such a great extent. I'm just not feeling that sympathy, I think, that maybe you were going for. So I'm not trying to be offensive here. I'm just trying to give you some feedback on the arguments that you just laid out. And I feel like the program is good. The industry partners have done a fantastic job in innovation. I love our American companies that do this. However, I think that they are quite profitable. Their market is growing in a huge, huge way, and that this is a small program in the great scheme of things here, and it definitely benefits the patients that are in my district. So just thanks for listening to the words, and thanks for being here.
Appreciate your comments. No offense taken. I think, again, like I said, we are not here to try and do away with this program at all. We think it does serve a vital purpose, and we would also just like to reiterate that we continue to provide significant discounts through not just this program, but like I said, kind of 187 billion in other price concessions and discounts as well. So appreciate the comments.
Senator Gossage.
Thank you so much for being here. I had the same question that Representative Concanon said about the no evidence that patients are getting discounts. Did you actually address that question? Can you tell us what you are seeing that says that the patients are not getting the discounts?
Yeah, sure, absolutely. So there have been several independent government reports to Congress, one from the Office of Inspector General and a second one from the Government Accountability Office looking into the 340B program. And they actually surveyed the program participants, the covered entities, to see if they were actually passing on those discounts to uninsured patients. And so in less than half the cases, they were not. So those are from government reports, and we're happy to follow up with that information and any forthcoming information that we may have. We're happy to share that.
Thank you. Also, it was mentioned earlier that pharmacies' expectations are that they would, and again, as you said, 60% of this are the big pharmacy chains, not the independents that were here today. So of the big pharmaceutical chains that are, of course, making billions of dollars and buying insurance companies, et cetera, they're asking for the same reimbursement that they get from 340B that they get from an individual payer. We know that the reimbursement is always less to a provider if they accept Medicaid. We know it's less to a provider if they accept Medicare. They couldn't possibly stay open. If they only accepted Medicaid patients and Medicare patients, the reimbursement would be way too low. the indication is that they would make up the difference with their private payers. If there can be no difference with the private payer and the 340B, again, most of this is going to very large pharmacies and the chain pharmacies, and they're asking for that as well. Is that my understanding?
You know, I'm not sure on that. You know, that might be a more appropriate question for the Pharmacy Association that maybe represents, you know, all different types of pharmacies. Again, and we don't, from our standpoint, have insight into how those contracts are necessarily structured. But again, I think you could potentially, you know, deduct that, you know, if a PBM owns its own pharmacy, or they have their own pharmacy in the network, that they're also probably cutting different rates to, you know, to their own chain pharmacies than they are to the independent pharmacies. So again, this is part of, you know, some of the concerns about just the overall sustainability of the program, and those smaller, like I said, true safety net community providers. You know, if so much of the profits are being funneled, you know, towards other large, you know, for-profit corporations.
And so even though they're a nonprofit hospital, they can contract with lots of pharmacies, and then those pharmacies can get those discounts and pass it along to the hospital. Is that what I'm understanding on one of the pages here? I think it was page,
Yes.
It's not identified as a page
Yes.
number.
So, so yes, essentially, you know, there are no rules around whether or not a nonprofit hospital has to continue to partner with a nonprofit or a smaller independent community pharmacy that isn't publicly traded. There are no rules around who a hospital can partner with. The only rule is that the hospital itself has to be nonprofit to have access to the discounts.
And so then could be, would you say, one of the reasons why we're seeing the Aetna, Cigna, United Healthcare, Cigna bought out Aetna. We're seeing these kinds of transactions because of what is happening with 340B. Could that be contributing inadvertently? I'm sure it was never intended to be that way.
You know,
that lots of the dollars are flooding into their pockets.
Yeah, I mean, I think you put it perfectly. It may have just been a happy accident for them, but they kind of saw the potential, you know, for 340B to be streamlined if they kind of kept it all within one parent company.
Thank you, Madam Chair.
Representative Wolfmore.
Thank you, Madam Chair. In your key takeaways, one of the things you said is middlemen are diverting profits away from the safety net 340B program to boost their bottom lines. No way to ensure that patients have access. So when you're talking about middlemen, are you talking about the pharmacy benefit managers? Is that who you're referring to?
Yeah, mostly the pharmacy benefit managers. You know, there are some smaller companies and vendors out there who also assist. There's some technological vendors out there that help these pharmacies. You know, with their contracts with the hospitals, or with, you know, the claims processing. I think you've heard about a couple of third-party administrators that help with the claims processing as well. But yeah, I mean, generally, it's PBMs here.
So you're saying that they're holding on to some of these benefits that should flow down to the covered entities that aren't because of the PBMs at times, correct?
Yeah, and more importantly, flowing all the way down to the patients, and so that the patient can benefit.
Thank you very much. Thank you, Madam Chair.
Representative Miller.
Thank you, Madam Chair. Ms. Hall, I take it that that's your photo on the material, not just some person?
It's actually just a stock photo, but I appreciate that.
Oh, okay. Well, I was going to stare at the picture when I asked you the question.
Oh, you can do that.
We had material given to us this morning that indicated that there were 8 manufacturers that currently exclude contract pharmacies, but that only represents about 6% of the 340B purchases. Is that just the tip of the iceberg? Can we expect that number to grow now that trend has begun?
Yeah, that's a great question. So, you know, I unfortunately am, as as a trade organization, have no insight into the business decisions that some individual companies may make. And so I'm not at liberty to speak to that, unfortunately, or give you any additional insight into what may or may not happen.
All right, well, then you may not be able to answer my next question. We had complaints, or at least I took it the nature of complaints this morning about, I thought it was manufacturers who are now demanding patient information to verify what I thought was whether the discounts were being passed to patients. Did you hear that testimony?
I may have missed it.
Well, my question was going to be, if the manufacturers who were asking for that are empathetic to the difficulty as it relates to privacy laws of the covered entities providing that information, but you may not be able to address that.
Yeah, unfortunately, without more information, I can't answer that. I'll just say at a higher level, again, we as an industry just want to make sure that 340B patients and those patients who should have qualified for the discounts are getting them, and we would want to ensure that their privacy is protected at the utmost. That's the highest priority and importance, that their privacy is protected. I can't imagine that they would be asking for specific information, but again, sorry, without hearing the earlier portion, I probably can't answer that question fully.
Well, because you stressed that that was your primary concern, was that the discounts were being passed along, I was trying to justify why someone would be asking for patient-sensitive information, and particularly being in the industry, not be, again, empathetic to that difficulty. But thank you. Thank you, Madam Chair. Mr. Chair. I'm sure he didn't mean to be offensive then either, but he was, wasn't he?
Representative Carpenter.
Thank you, Madam Chair. Just to piggyback on a little bit of what Representative Wolf was talking about, in the middleman section here, that mainly for-profit pharmacies and middlemen are diverting profits. Would that be large providers also?
In terms of larger hospital providers, it certainly could be. We do have some data as well that shows that hospitals again are able to, like I said, when we talked about that spread, they're able to either purchase almost as low as a penny, but then they also on the commercial side are charging commercial payers sometimes 3 to 5 times as much. They're marking up these drugs, but they were able to acquire them at lower prices. So that is a concern as well in terms of how the discounts are maybe being mishandled or misused and abused. So yes, it can certainly include larger hospitals.
Well, I kind of noticed you shied away from that. Madam Chair, can I have one more question here? So at the bottom of your takeaways here, increased transparency to ensure greater accountability and tracking of 340B discounts so patients can benefit. So what are your thoughts on that? And as a manufacturer, why can't you control that?
Isn't that the $1 million question of the day? That's a great question. I think this program is, like I said, based on rules that were written in 1992, and here we are trying to operate in 2022, right? And like I said, when it started out small and it was one health clinic writing a script, sometimes they would write that script on a different pad, like a different colored paper, so that when the patient took it down to the pharmacy, they would know, oh, this is a 340B patient, or oh, I know to provide cost sharing on a sliding scale based on their income level. Those were the simple early days, right? Now we have these real-time prescription claims that Ms. Freeman talked about. It can be difficult to identify those claims when they're dispensing. Don't know why we still have this backwards program, but I think from the manufacturer's perspective, and there are also certain reasons because of Medicaid, where manufacturers by law are not supposed to pay both a Medicaid rebate and a 340B discount on the same prescription. But we know that that still sometimes happens because it's slipping through, and the PBMs who are also the managed care provider for the state Medicaid program is not always catching these claims. So for a variety of reasons, and I think from the manufacturer's perspective, we don't need to know down to the Jane Doe level that Jane Doe is a 340B patient. We just want to know on the aggregate that these claims de-identified, not with the patient-specific information, but we just need to know that this bucket of claims should be tagged as 340B. This bucket of claims should be tagged as Medicare Part D. This bucket of claims should be tagged as Medicaid, because we're sometimes finding ourselves paying double, if not 3 times the discounts and rebates, sometimes even on the same prescription claim, right? And so, if there's a way that these claims can be more easily identified just for tracking purposes, just so that the bean counters at our companies know which bucket it should have been billed to, that's a solution that we would, like to continue to work with everyone on.
Very good, thank you. The other thing is, the old days, the 340B drugs were all locked up. And
That's
they
right.
Yeah,
Right.
so.
Representative Wolfmore, oh, no, I had Landwehr next.
I would be happy to yield to Representative Wolfmore. Going back to the transparency issue, and I think it's, there's a lot of contractual things that occur in this world of prescription programs. And I know that in the CAP Journal today, there was a discussion about the HCC having a redacted program on about $100,000 in drug spending for state employees' health plan. And so I guess my question is, if we're going to look at transparency, do we look at transparency across the board? We look at it within the pharmacies, we look at it within the clinics, we look at it within pharma. How far do we take the transparency?
Yeah, that's a great question. So, we'll just start by saying you're right. On the contractual side, there are terms in there that are just between the trading partners, and we're not looking to get down into that level. I think it's more from a claims processing standpoint, like I said, so that we all are playing, above board, and all the contributors in the supply chain know exactly, which claims should be tagged. They shouldn't be tagged to 3 different payers. It should really just be one in one program. That's what we're looking for when we talk about transparency here. It's not so much, the prices or anything like that. It's really just, which bucket should this have gone to and who should have paid for it.
One more question, Madam Chair. Well, and in that statement, it says, so patients can benefit as the program intended. So what patients do you feel like are not benefiting from the program?
Right, that's a great question. So right now, because of the mix and the inventory that we had talked about, so you're able to still bill, commercial insurance, even on a 340B drug, or sometimes patients who truly were seen by a 340B provider and are indigent and should have gotten a 340B price are not getting that discount. So it's more targeted, intentional benefits for patients who qualified truly for 340B and are getting access to that discount, at the pharmacy counter today.
Thank you.
Representative Wolfmore.
Thank you, Madam Chair. I just wanted to follow up on that transparency a little bit. So if there's concerns with hospitals, the way I understand it, that the drug manufacturers can open an audit anytime they want on hospitals or any other entity. What they can't do, I believe, is open an audit on PBM. So that sort of is the difference there on transparency and how you look at those 2 different groups. Correct?
No, manufacturers can certainly, manufacturers do have audits with PBMs whenever they want to dispute claims, both within 340B and outside of 340B. I just think that that's a tremendously arduous and lengthy and costly process on both ends. And so, that's almost like pouring salt into our wound that, we've already paid a discount, and now we're needing to pay even more to chase that down and audit it when, I think, again, for efficiency's sake, if everyone knew, what the claim was and who should have paid for it, it would save a lot of time and headache in needing to go down and audit and dispute process.
With the HRSA audits, I know those can be publicly seen. Are those public, the audits you do on the PBMs?
No, they're typically not, just because they're private trading partners.
That's right. I assumed. Okay. Thank you very much. Thank you, Madam Chair.
Sure.
Senator Erickson.
Thank you, Madam Chair, and thank you so much, Carolyn, for your information today. Just a quick question. Sorry about my microphone. Are you aware of any other industry or manufacturer that's subjected to a government program like this to address a societal need?
That's a great question. Not off the top of my head. I might have to do a little bit of homework on that, but no, not off the top of my head. And like I said, this is a program that is fully funded just from one industry.
Thank you, Madam Chair.
Further questions? Representative Tarwater.
Thank you, Madam Chair. I was just sitting here thinking, is there, there's not a lot of accountability on where these dollars are spent, but is there a limit on where these dollars are spent? Are there certain programs that they have to be used for, or can they be used for anything at all, including bottom line profit?
Yeah, that's a great question. So, the way I characterize it is no strings attached. There's very little reporting, if you will. There are certain reporting requirements for the amount of like charity care, perhaps, that or qualifications for charity care that they have to provide to indigent patients. But aside from, like what they actually do with the discounts or where the discounts go, or how many 340B patients were helped, or how many 340B patients were able to have their medications discounted, or how much by discounted, we'd love to know. Like I said, from a tracking standpoint, all we know is it's $40 billion out the door, and we don't see that.
Okay, I don't see any further questions. Senator Ware.
Thank you so much, Madam Chair. So you just said $40 billion out the door. $40 billion out of what? What's the total? How much of your I don't know what term to use, total business is $40 billion?
That's a good question. I'd have to try and go back and think about the context of that, but out of that's part of the kind of almost 200 billion as an industry in 1 year that we're giving away, in addition to not just the 340B discounts, but in total it was 187 billion in other rebates and discounts and price concessions for other federal programs and commercial rebates as well. But I'll try to put that into context. Again, these are kind of more industry wide numbers across our membership. So it's going to vary from company to company in terms of their exposure to 340B or other federal programs.
Thank you.
Okay, now I think we have no further questions. So thank you for joining us.
Of course, it's my pleasure.
Okay, next up we have safety net clinics. First up, we have Denise Sisman. And Denise, while you're coming up, I've been thinking about the request for the amount that was paid for the testimony or the services of the attorney. if you guys want to talk about that in private, that's fine, but I don't want in committee to start asking, I don't want to ask Carolyn how much she was paid and the lobbyists. I just don't think we need to start down that road. My thinking as far as transparency was just so that everyone knew who paid. And so with that, if you want to talk about anything else, talk about that, that's fine, but I just wanted to make that clear before you started.
Okay, thank you for that guidance. Chair Concanon, Vice Chair Erickson, and committee members, good afternoon. I am Denise Sisman, the CEO of Community Care Network of Kansas. And we do thank you for allowing us to present about one of the most important programs for Kansas Community Health Centers, which is the 340B program, the topic of the day. With me are Matthew Schmidt, who is the CEO of Health Ministries Clinic, and he is our board president for the board of directors, and Derek Peel, who is an executive director of pharmacy services at Salina Family Health Care Center and is also a national expert in 340B. Community Care, many of you know, represents a network of community-based clinics that serve all Kansans, and they specialize in providing care to the most vulnerable and underserved. 1 in 10 Kansans receive medical, dental, mental health, substance abuse, and other types of services by and through community health centers. Most patients work in low-income jobs, do not have health insurance, or are Medicaid beneficiaries. They experience multiple economic and social barriers to health, and health centers do also provide services to alleviate those barriers, most of which are not reimbursable services. Today, we're going to focus on the pharmacy program, which is provided largely in concert with the 340B program. And you've heard a lot about what the program is, how it works, why it was created, and all of that. I'd like to take that national program, though, and make it local by sharing the health center experience, the health centers that are in your districts. We will talk about what's working as well as current threats. And the biggest threat to us is the large out-of-state corporations that are for-profit that are working to undermine the program by increasing their bottom lines, by taking some of that savings that we've been talking about. These threats are real, they are happening now, and they are escalating. You have heard from speakers this morning how 340B is used to increase access to care and to reach more patients. That's music to us. That's exactly what we're all about. And I thank you for bringing the patients up so much during this discussion. Kansas Community Health Centers meet the 340B mandate, which is to stretch scarce federal resources. In 2020, they dispensed just over 1.5 million prescriptions to more than 56,000 Kansans. You can get this data, by the way, through the HRSA website. It is public data. They have reinvested more than $21.7 million into their patients and communities, $21.7 million from the 340B program. For example, and you've heard some of these examples already today, all health centers provide free or reduced cost prescription drugs. And with the rapidly rising cost of medications, this helps a wide variety of folks, but especially those who are uninsured or underinsured or who have low income. They provide uncompensated care. Health centers serve everyone regardless of ability to pay, and the 340B program is critical to help them meet this requirement. The 340B savings helps to pay for medical, dental, mental health, and substance use disorder, and all kinds of other care, including the care that's not reimbursed, to address the social determinants of health. They provide this to all Kansans, but again, especially those who are uninsured or underinsured. The 340B savings are used to expand facilities and add new services. One great example is a health center that used part of their 340B, or they used their 340B savings to help open a vision and optical clinic, meeting the need for optical, and vision services in their community. They also use it to provide non-reimbursed services, and you've heard, again, some of these examples. One that I really like to share is that one health center uses 340B savings from insulin and diabetes oral medications to cover the cost of glucometers and blood glucose strips. These are supplies that are often not covered by insurance, but are necessary to achieve diabetes control. The 340B program is an economic investment in Kansas. As health centers hire additional staff, they purchase more goods, and expand their footprint. 340B savings are cycled back into their communities. In this way, the $21.7 million in savings added $38 million in additional economic activity within Kansas communities. We did a recent analysis, and most of the economic benefit was experienced in rural Kansas, as rural health centers, realized nearly 71% of the total 340B savings for health centers. It is a rare program that costs the state nothing and yields significant economic benefits. You've heard a lot about whether there's accountability on how to use the 340B savings. We can guarantee health centers are good stewards of the program. By law, by regulation, and by mission, they use the program as intended to stretch scarce federal resources to serve more and do more. I would also add that they help to stretch scarce state resources. And there are strings attached. HRSA monitors health center compliance in multiple ways. There are annual audits of these programs, and the pharmaceutical manufacturers also have an oversight process to identify and resolve potential problems, particularly related to duplicate discounts with the Medicaid program. Kansas is in danger of losing 340B because large out-of-state pharmacy benefit managers are taking steps to capture the savings, and we've heard a lot about this already. We call this practice discriminatory contracting. You've heard that as well, as they reduce reimbursements, impose restrictions, or establish additional fees or costs on 340B health center pharmacies. One may ask, why would a health center sign contracts with unfair terms? The PBM contracts are presented as a take it or leave it type of scenario. If the health center does not sign the contract, they would be unable to provide prescriptions to their patients at affordable cost. The damages from these contract terms are meaningful and sizable to health centers, yet only add small amounts to the PBM's pockets. The 340B savings for Kansas health centers accounts for 0.5% of the Kansas prescription market. Yet the loss of $21.7 million would result in devastating cuts for health centers. Sites would close, employees would be laid off, services discontinued or reduced, and most importantly, access to care would be decreased. We also would likely be at your door saying that we have to continue many of these services and we would need additional state funding to do so. Because the PBMs are national companies, discriminatory contracting occurs across the United States. We have talked already about 16 states that have enacted laws to stop this practice. These bills, it's important to note, have passed with overwhelming majorities in their state legislators and sometimes even unanimously. If you look at the map that we've provided, you will see that many of these states are like Kansas in makeup and political philosophy. By supporting 340B legislation in Kansas, you would stand with your colleagues taking reasonable steps to stop this threat. You would also stand with other Kansas elected officials, members of the Kansas congressional delegation, and you've heard from Representative LaTurner's office, and Attorney General Schmidt want to protect the 340B program. In fact, the Attorney General co-led 28 of his counterparts in writing that December 2020 letter to then HHS Secretary Azar, urging HHS to protect the program. He was one of 33 attorneys general that filed an amicus brief for the U.S. Supreme Court case, which ended in a unanimous decision by the justices supporting the validity of states' rights to regulate PBM contracts. The 340B program is at risk not by fraud, not by abuse, but by damage from large out-of-state companies whose bottom lines are hardly threatened by 340B entities in Kansas. We thank this special committee for holding this meeting to better understand the program and what is at risk. We ask that you recommend to the 2022 legislature that now is the time to protect the program. We cannot afford to wait until irreparable damage has been done. As these threats continue and grow, make no doubt, Kansas will lose, Kansans will lose, and big corporations will win. I'm now pleased to introduce Derek Peel, Executive Vice President of Pharmacy for Salina Family Healthcare.
Derek, welcome to the committee.
Thank you, Chair Kincannon, Vice Chair Erickson, and committee members. We greatly appreciate the time we've been given today. My name is Derek Peel, and I'm the Executive Director of Pharmacy Services at Salina Family Healthcare Center. We are a federally qualified health center that serves Salina and the surrounding area. I'm actually going to go a little off script here, so I wanted to clarify a couple things I've heard in some of the other testimonies just real quick. One of your questions was about 340B eligibility and what would qualify for charity care and what would go into to support services. So I can speak from a community health center perspective from what we do. I like to explain it as two separate arms. One arm, so as a community health center, we get a discount on our medication from 340B. So one arm would be to give that through charity care directly to a patient who would qualify for it. And then there's another arm that would support all the services like what Denise was speaking about and what we have listed in our written testimony. So that's by design, kind of those two different arms. So that was one thing I wanted to clear up. Hopefully that helped clear that up a little bit. The other thing, you're going to hear me talk a little bit about submission clarification codes and billing requirements. And it's going to sound like I'm against it. So I just want to say that I've heard about transparency being mentioned, and we are not against transparency. That's something that we believe in as well. The problem is that some of this data requests and flagging claims as 340B really is just serving to put a target on these 340B prescriptions that at this point we have no protection against this 340B discriminatory contracting that I'm about to talk about. So I just want to say that this is step one of what we need for transparency is to be talking about how to prevent this discriminatory contracting problem. So sorry, back to the regularly scheduled program here. Obviously you've all heard all about 340B today, including the importance of the program and what is at stake. You know, there is a lot to talk about with 340B, including contract pharmacy issues, but today I'm here to specifically tell you about Salina Family's experience with 340B discriminatory contracting as one example of the confusing and concerning problem that community health center pharmacies across the state are experiencing. So in the spring of 2018, our in-house pharmacy, Salina Family Healthcare Pharmacy, received notice from the PBM Express Scripts that they were no longer going to contract with us unless we made what amounted to extensive process and organizational changes involving how we contract with PBMs and how we dispense prescriptions, including 340B prescriptions. It was during this process that we first realized PBMs were we first realized PBMs were treating 340B pharmacies differently than other pharmacies. That obviously caused a lot of stress and worry about whether we'd be able to make the required changes to continue caring for our patients with insurance and the potential devastating effects not being able to would have on our 340B supported services. Eventually, we succeeded in making the changes, which meant we'd be able to continue accepting insurance and wouldn't need to cut out our 340B services or, God forbid, cut any staff. So, problem solved, right? Well, no, not exactly. Unfortunately, just a few months later, we received notice from the PBM CVS Caremark that we were identified as a pharmacy owned by a 340B covered entity that serves only 340B eligible patients, and we would no longer qualify to be in their commercial network. So after several attempts, we eventually succeeded in speaking with 2 CVS Caremark employees to explain that we had already made the necessary changes originally required by Express Scripts. Unfortunately, they said that it did not matter that we had made these changes. CVS Caremark was not willing to let us stay in our current contract. They said the issue was that we were listed as being owned by a 340B covered entity on our required National Council for Prescription Drug Programs profile. This meant that drug manufacturers could decide to hold back paying them drug rebate money for prescriptions filled at our pharmacy. I want to pause for a moment to say the kind of drug rebates CVS Caremark was referring to are not required, such as the ones that help fund Medicaid. These rebates are business transactions voluntarily negotiated between drug manufacturers and PBMs for manufacturers to get their drugs on PBM formularies, and they should have nothing to do with 340B program. But that is not the case because of what PBMs are doing to 340B covered entity-owned pharmacies. So back to CVS Caremark. After considerable back and forth, CVS Caremark agreed to let us continue in their commercial network, but only if we agreed to a 340B contract amendment that reduced our reimbursement to make up for possible lost rebate money. In the end, we did reluctantly agree to sign their 340B amendment. Later in the fall of 2018, we had a similar experience with Humana's PBM. After considerable back and forth with 2 of their employees, we agreed to a contract that reduced our reimbursement for any 340B prescriptions so long as we flagged them with an electronic submission clarification code. After our experiences with CVS Caremark and Humana, I looked into our other PBM contracts, and actually to my surprise, I found that the initial contract we signed with the PBM Optum Rx when we first opened our pharmacy back in late 2013 contained language that reduced our reimbursement based on 340B prescriptions. And now recent updates to their provider manual also require us to submit electronic submission clarification codes for 340B prescriptions. So things stayed relatively quiet from there until earlier this year when Express Scripts put out a nationwide notice that all 340B claims must be identified with an electronic submission clarification code. And this one was a little bit unique because it's the one that Dr. Friedman was talking about that you have to put on after the fact, not before. So it really makes it tough for contract pharmacies to essentially participate in 340B with these retroactive billing requirements. So to this point, Express Scripts says these billing requirements will not change our reimbursement, but I'm not alone in suspecting this will eventually lead to further reductions from them. Collectively, these 4 PBMs control 85% of all prescription claim processing, and CVS Caremark alone accounts for nearly 1/3 of all prescription claim processing. Consequently, we had no choice but to sign these take-it-or-leave-it contracts to keep from cutting our 340B supported services and staff. Attached to our written testimony is our 340B program savings impact statement that details these vital services and the staff necessary to provide them. Look, I know you've been here all day hearing about 340B, and paying attention to all of this was probably tough. This is confusing and complicated, but that's exactly how it's been for us. There was no 340B discriminatory contracting course in pharmacy school or handbook that I could use. So much of my time has gone to understanding and navigating these continually changing requirements and payment reductions. Time that I could have been using to help care for our patients at our health center. A perfect example is that I'm here today instead of at Salina Family doing what I was actually hired to do. Despite that, I want to reiterate how thankful I am that we're having this discussion today and hopefully working towards a solution. I hope our story has helped shed light on what is actually happening and the amount of time and resources that have been diverted to it. This is not just our story. All Kansas Health Center-owned pharmacies that participate in the 340B drug pricing program and their patients are affected by this. As it stands, all Kansas Health Center-owned pharmacies are completely vulnerable to further 340B prescription requirements and reimbursement reductions that we are confident will happen. If permitted to continue, this will absolutely increase healthcare costs in our state and negatively affect the health of Kansans. Passing legislation that protects against these practices and keeps 340B working as it was intended is paramount to protecting the health of Kansans. 16 states have already done this because it makes sense. There is simply no logical argument for allowing these out-of-state PBMs to continue manipulating a tax-free program that exponentially impacts the health of Kansans and the fiscal health of our state. House Bill 2260 and Senate Bill 128 will stop this. With that, I ask that you please let us hold hearings on these bills in the committees where they were introduced. Thank you once again, and I'll turn it over to Matthew Schmidt, CEO of Health Ministries.
Hi, welcome to committee.
Thank you. Short people. Oh, yes. Chair Concanon, Vice Chair Erickson, and members of the special committee, thank you for the opportunity to present testimony on this vital issue. I think one thing you have working in your favor is both of my legs fell asleep while I was sitting back there. I don't know how long I can stand, so I'll try to move quickly. As Denise noted, I am the CEO at Health Ministries Clinic, a community health center serving Harvey County and surrounding communities. Today, I not only represent myself, but my colleagues at community health centers throughout the state who are on the front lines working to ensure that all Kansans have access to high-quality health care no matter their income or insurance status. Community health centers not only serve as the safety net provider for many of our state's most vulnerable populations, but also act as powerful economic engines in the communities we serve, especially in the rural areas of the state. Under Section 340B of the Public Health Service Act, it bears repeating that in exchange for having their medications covered by Medicaid and Medicare, the pharmaceutical manufacturers agreed to provide front-end discounts on covered outpatient drugs purchased by eligible covered entities that disproportionately serve the nation's most vulnerable populations. We are concerned about business practices by intermediaries called pharmacy benefit managers, or PBMs, that threaten to alter this agreement and weaken the 340B program fundamentally. This is both a complex issue and a simple one. In its most basic terms, we are concerned that if left unchecked, resources that are intended to meet the needs of Kansans will be diverted to out-of-state corporations. If the 340B program is weakened, this will unequivocally impact the ability of Kansas healthcare providers to meet the needs of the vulnerable populations we serve and ultimately have negative economic consequences on our state. The legislative solutions we seek not only strengthen the healthcare infrastructure in Kansas and work to protect access to care for many of its most vulnerable citizens, but also make pure economic sense for our state. To date, 16 other states, many with similar philosophical profiles to Kansas, have already taken steps to do just this. We believe that legislative action to simply preserve a program intended to stretch scarce public resources is both pro-Kansas and pro-Kansas business. We desire to ensure that the benefits of the 340B program are protected and utilized in the manner for which they were intended. We want to make certain this money stays in Kansas to help clinics in your communities treat and serve your friends and neighbors. It's been mentioned that it feels like patients are being left out. Heard that a couple times today. Let me tell you that patients are absolutely at the center of decisions that your Kansas community health centers make every day. The 340B program allows entities like community health centers to do two critical things. First and foremost, it gives us a mechanism to help guarantee that our patients, who disproportionately include the uninsured, underinsured, and those with Medicaid, can obtain medications ordered by their physicians. This eliminates our patients from having to make the all-too-real choice between filling their prescription and paying rent or buying groceries. This is a powerful resource that has a profound impact on the lives of those we serve, and we see it every day. In addition, the 340B program allows us to benefit our patients in a second significant way. This gets a little bit to what Derek was talking about. The payments for medications we receive are cycled back into services designed to benefit all of the patients we serve, including those with Medicaid. This helps support things like integrating primary care and behavioral health, case management, diabetes education, transportation, and other assistive services that help break down barriers to care but often don't have a means of reimbursement. These benefits are often magnified in the many rural communities in which we serve. Again, I can't speak to what is going on at the out-of-state entities, but I can speak to the realities of Kansas. You cannot overstate the importance of the 340B program to safety net clinics. It would be hard to identify a more disruptive and destabilizing action to the health center network currently serving 1 in 10 Kansans than to allow the resources of this program to be fundamentally altered. The Community Health Center program is one of the most widely bipartisan supported healthcare programs in the country. Why? Because it works. Community health centers consistently produce high-quality outcomes and save the healthcare system money. The 340B program has served as a cornerstone of these efforts for over 30 years. The program is now being placed at risk. We ask for your assistance in providing a legislative solution to support Kansas community health centers and continuing to effectively meet our mission to serve the individuals in this great state. Thank you.
Thank you. Okay, well, that's it for the safety net clinics. Do we have any questions for them? Senator Gossage.
Thank you, Madam Chair. My question is for the individual from Salina Family Healthcare. Thank you for coming and for your testimony.
Thank you for having me.
I know you may not have it in front of you. In the second paragraph, you were explaining how the savings is achieved. And you say it's achieved by selling prescriptions at a regular market rate to patients that have private insurance. So for example, if the PBM or the manufacturer would give you the discount on an individual patient that they would give on somebody who qualified or was eligible for the 340B program, you would get that same discount. So a drug that would normally be $30, you would get for $10. And it says then you would charge $30 to sell it to the same market price, and you would pocket the $20 difference. That's in your paragraph 2.
Right, okay, so is the question, what's?
So I'm just clarifying that when you're talking about discrimination, wouldn't it be discriminatory in that if it was a non-340B participating pharmacy, they would have to pay the $30, right?
So,
but you only have to pay the
this
10.
is only for, so the example is, and I apologize, I hope I'm understanding your question correctly. But the example is supposed to show that, okay, so if we would get paid the same amount that any other pharmacy would, that because we can buy that just a little bit less, that difference represents that 340B savings that we can reinvest in and multiply into all of the services that we can provide our patients.
I understand that.
Okay.
So, but what I'm trying to clarify and what you say here is that as a 340B pharmacy or provider, then you want to get the discount, for 340B discount for all of the prescriptions that you write, and that would include a private individual, a private person who comes in with their insurance card.
Okay.
And then you pocket the difference by selling it back to that, charging that person the $30. Though you paid $10, so you get to keep the $20. Where if I were a pharmacy that was a non-340B participating pharmacy, I would have to pay the $30 and charge the $30. There would be no savings there because it wouldn't get the 340B savings on an individual private payer.
You mind if I answer that question?
Yes, no, not at all.
I think that's exactly what the program is. I mean, you're describing the program. And so when it's not really broke up into, so the 340B, partly what that has to do is that upfront acquisition cost in the case of what we have. When we have patients on Medicaid or uninsured, part of the business end on our end is sometimes we fill those medications at a loss. And so I think it was mentioned earlier, sometimes with that 340B, that acquisition price does is helps us lessen that loss. But when we have an insured patient, we have a lower acquisition cost. What we're asking for is that on the insurance company side, that PBM side, that we are charged or the same amount that any other pharmacy would be charged at that point. So that's the piece that we're looking at. Does that help that at all?
Not really. The reason I'm saying not really is that's not what this paragraph says. It says that you consider the following example to be better understand. If a 340B covered entity purchases a drug for $10, that would cost a non-340B pharmacy $30. So you're not getting the same price that a non-340B.
No, our acquisition price is different. You are correct.
Okay, so you would be getting it for less, but selling it for more, and that's where you get the savings.
That's the
where
heart
you're
of the
talking
program,
about.
yes.
Thank you.
I mean, yeah, sell it for the same price, excuse me, not for more. We're looking to sell it for the same price. It's the acquisition price that was less.
So you're asking to get a lower price, to pay a lower price.
We already get the lower price. What we're asking for is to be reimbursed the same.
Thank you.
Senator Erickson.
Thank you, Madam Chair, and thank you so much for being here and all that you do for our communities in Kansas. Okay, I don't know what's wrong. It's getting close to Halloween, I guess. Okay. So just a quick question, and I don't know if this is something for you or another conferee, but are there overhead or administrative costs that are paid for with these 340B savings dollars?
You mean at any place or any place in the program?
Right. I would assume that you have some administrative or overhead costs to implement the program.
Yes.
Are those taken? Okay. Do you have any idea how much of the money that's intended for this drug reduction goes to administrative or overhead costs?
I could work to get that. I'm not sure what the exact percent of the overhead cost of administering that program internally would be.
Okay. Thank you very much. Thank you, Madam Chair.
I will say, excuse me, I was just thinking, like, when I think internally, like where we have money allocated towards that, I would say in terms of staffing positions, we have people on staff that look to ensure that the program is being administered correctly and that there are no duplicate discounts. So some of that oversight piece that we're talking about, we do have somebody on staff who's that is their position to make sure that those things and that we're adhering to the program compliance standards. That would be the most relevant overhead costs that we would incur.
Yeah, I think I heard earlier today a conferee state that it's wide open, that you can spend your 340B money on anything, and it's broad. It's not specific, but it does have to improve access to care.
Yeah, and I think the broadness of it is because communities are different. And so when you look at that, different communities have different needs. I know in our community, transportation is a huge issue and a huge barrier. And so that's part of where our funds go. I know, I mean, Derek spoke to it. I know this is how we would do it in our place too. And I think many do that. We keep a listing and an accounting for where that 340B, any savings that we're able to occur in there, where that revenue goes, and what programs that we have that allocated for, and what we're able to do, and where that goes. For example, I know for us, one of the things, in our area, in many areas. Mental health is a huge issue, and psychiatry is an expensive and a huge issue. We have psychiatry on staff. That in part is a service that loses money for us. It's not one that is self-supported by patient fees, and so that's an example of a place where we would allocate some of our 340B savings. And again, we have that documented, and we would feel very comfortable talking to people about it. We're proud. Actually, we're proud about it, and we don't mind talking about it because we believe all the things that we're doing improve situations in our communities.
Okay, I want to talk just a second about the contracts. So the proviso that I introduced last session stated that the PBMs could not discriminate between 340B and non-340B contracts. How do you know that they are? And well, just let me hear a response to that.
Well, I think part of that was the issue that was brought up when word started coming down that they were only going to allow people to contract with one pharmacy. And we already mentioned, it was highlighted here too, especially in rural areas of our state, how difficult that can be. I know, like, just as an example, for us, it's an access issue in our community. From a business standpoint, I would rather, we operate our own pharmacy, and we have contract pharmacy arrangements. From a business standpoint, I would love for everybody to fill all those scripts in my pharmacy. That would be better for me as a business. We believe it's better for our patients to have access. And so we choose to engage in these contracts where we create additional access for our patients. That's, in our case, I can say we believe strongly enough in that's why, that speaks to the importance of it for us. I don't know if that, I'm not sure if I actually answered your question or not, but I guess that's the clearest answer I can give into explaining the importance of those pharmacies in certain areas.
Yeah, I understand the importance. It's just, how did you know? How do you know that they're discriminating?
You're talking about the actual PBM contract with us? Is it not the contract pharmacy?
No, not the contract pharmacy. I'm talking about the PBM contract with you.
With us.
That was the subject of the proviso that I introduced.
Well, quite frankly, I mean, I have it. I could, my chief compliance officer might be watching right now going, what are you doing? I would love nothing more than to show you that contract that has different terms in it, but there are confidentiality statements all over in our contract saying that we cannot share that. Again, I wish our PBM friends were here, but they would potentially be able to give us permission to share those contracts with you. I can only pass along our experience and tell you that, in our contracts, they're, just the ones that I talked about as far as lowering our reimbursements or putting on terms that we have to do billing requirements are in there. But without, not being held liable for actually showing you the terms, I can't just say, here it is. Yes.
Just a sec.
Oh, sorry.
Also then, last spring when I was working on the proviso, there was some urgency to this issue.
Mm-hmm.
And I guess I'm wondering what's the end result if this does not get some kind of a resolution?
Right.
Without any hyperbole, just tell me straight up, what's this do to you?
Yeah. So the end result, if nothing is done, it's going to continue to grow to a point where essentially, even as Dr. Ha kind of alluded to, that PBMs and middlemen will be able to take away from the program to where it's almost, we like to use an analogy of a hose, right? Okay, so you want to get the water to one end to the patient, but there's all these holes that people are poking in the hose, and eventually the water's not going to make it to the end and be able to even be there for the patient. That there won't be a 340B program, and then everything that is supported by it. For us, we've defined that as 13% of our direct patient care salaries. That's like 18 employees for us, and not to mention all of the healthcare costs that are going to be raised on the backside, because so much of what we do is preventative type of services, just like transportation. We deliver medications for free. We have care coordinators in our health community health center that don't just help people afford their medications and figure that part of it out. They help people keep their lights on. They help them with electricity bills, with everything that this person needs in their life, food vouchers. So we say if you've seen one community health center, you've seen one community health center. Every community health center is going to do something different. We are governed by actual patients on our board. We are going to do what our communities need, and 340B allows so much of what we do to be done. We've said that 340B is kind of the safety net for the safety net. And without it, there'd be just, like Matthew said, it's hard to think of if you were trying to come up with a way to devastate community health centers, this would be a really great way to do it. I hate to say it that way, but 340B is just critical to so many things. I don't even have the answer for you, because it's hard to even kind of go down that road and think about, we're talking about big time problems if this line is not drawn in the sand. So that's why we're here. We don't want it to get to that point, obviously.
Okay, thank you.
Absolutely.
Senator Gossage.
My question was answered.
Oh, her question was answered. I don't have anyone else. Oh, Representative Miller.
Thank you, Madam Chair. Denise passed around a map with some very impressive numbers in terms of how these various bills have passed the respective legislatures. Without looking at the bills, that may simply mean that they don't do much, and that's why nobody opposed them. And I'm serious about that. That happens. The fellow this morning drew our attention to the one in Arkansas as being what he called a model, and I haven't had a chance to review any of these or even the two that were mentioned in the testimony, House Bill 2260 and Senate Bill 128. I did have enough time to check the status of those, and while they were introduced, neither one even enjoyed a committee hearing. So my first question would be, how realistic is it that either one of those are going to go anywhere? And if you had your druthers, my second part is, might you want to look at perhaps something like HB 1881 to actually address the problem? I'm not interested in placebos. I'm spending my time on this committee to identify the problem and then hopefully support legislation that addresses the problem and that doesn't just wash over it. So does that sound like a question to you?
I think so, and let me know if I don't answer all of it. I believe that William Von, how do you say his name, Owen?
You can say it any way you want.
Okay, he's not here. I'm Sisman, so I get it. I think he had some really brief descriptions of each of the legislation. We have a nice packet that provides a summary of each of those if you're interested. A little light reading. They are significant bills, and they have been introduced over the past, I think 2019 might have been the first bill, so we are starting to see these being implemented and enforced. It's still a relatively new process, but we believe that these are the type of bills that need to be passed. The Arkansas bill is actually one that we haven't looked at because it came after we prepared our bill, so we haven't had a chance to dig deep into it. It is more comprehensive than what we are proposing. Does that answer your question?
I'm not sure I had a question, but your comments were constructive. Thank you.
All right, thank you.
Okay, I see no further questions. Thank you very much. Okay, now we'll hear from hospitals. Up first, we have Sarah Dodson from Ascension Via Christi. Welcome to the committee, Sarah.
I'm short, so I'll adjust. Good afternoon, Chairperson Kincannon and members of the committee. My name is Sarah Dodson. I live in Pittsburgh. I'm a pharmacist, and I'm our 340B program director for Ascension Via Christi. I work with our 340B eligible hospitals, clinics, and pharmacies in the Pittsburgh, Fort Scott, Wichita, Wellington, Manhattan, and Wamego communities. I'm here today to speak to you about the importance of the 340B program to our hospitals and, most importantly, to the patients that we serve, and to tell you about some of the challenges that we've seen arise over the last couple of years, which you've heard much about today, but just to share our firsthand experience with those. I want to pause, too, because we've heard a lot, kind of at the national level, and just to kind of relay a little bit of that to our communities here. I personally come from a family of teachers, farmers, and mechanics, all of which, most of my family members over the age of 50 have at least diabetes and high blood pressure. So my decision to become a pharmacist and my desire to practice in rural areas is based largely on my personal experiences growing up watching both my family members and friends and family members in our communities face the everyday challenges of doing their best to manage their chronic disease states, many of which include challenges in accessing care, whether that be acute care in a hospital, primary care, or specialty care. It also certainly includes juggling complex medication regimens and figuring out how to afford necessary prescriptions. In the early 90s, my grandfather suffered a stroke that left him disabled, altering the course of his life, but also the lives of my family, who helped care for him until he passed away. Today, I'm so thankful for the improvements that we have in stroke care, and I believe his outcome and the impact it had on our family would have been much different if it occurred today. One critical detail here is that the best outcome for stroke victims depend on a person's ability to quickly reach a hospital where they can receive treatment. I've thought of this often in past years as we've seen hospital closures across Kansas, and I'm proud of the work that Ascension Via Christi has done to put in freestanding emergency departments in both the Fort Scott and the Wellington communities to give those patients important access to care. And of course, while my emphasis here is on, my experience in rural communities, we know, of course, that these same challenges exist for patients all over Kansas, including in our urban areas. And I want to say that I don't share this because I think that I'm unique. In fact, quite the opposite. I think most of us have either dealt firsthand or know someone who's faced many of these same challenges that I've described. So as a pharmacist, when I first heard about the 340B program, after seeing my patients struggle firsthand with affording their medications, it was mind-boggling to me that we have a program which allows providers to help patients access these much-needed medications. The 340B program, as you've heard today, allows certain nonprofit safety net providers to access 340B pricing on outpatient medications. The stated intent of the program is to allow these safety net providers, who are called covered entities when participating in the 340B program, to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. Eligible entities include those who provide a disproportionate share of care for those who are uninsured or underinsured. To participate in the 340B program, each 340B covered entity must meet strict requirements and then must provide documentation of that eligibility, register with, and be approved by HRSA. I believe we have 84 hospitals participating in Kansas in the 340B program. It allows our hospitals to realize savings on medications, which we then use to fund a variety of services to directly support some of our most vulnerable patients. When discussing the 340B program, it's important to understand that while this is a federal program, the discounts received from pharmaceutical manufacturers, not from taxpayers. When a drug company wants prescriptions for their product to be paid for by CMS, they enter into an agreement to offer these discounted prices to eligible entities. I think we've also heard today that the 340B price calculation is set in statute. So when these companies agree to participate, they're required to offer the 340B price, but they don't determine what that price is. One important detail is that there's an inflationary penalty built into the calculation. So this means that when the list price of a given medication rises faster than the rate of inflation, the 340B price often drops even lower. While the Ascension Via Christi services supported by the 340B program are too numerous to list here in discussion, I have included an attachment in my written testimony, and details can also be found on our website. As mentioned, all of this is public: how much we save, how we use our savings, which of our sites participate in 340B. All of those things are registered in a public database with HRSA, and then we also host our own website to share about the impact that 340B has in our communities. If I could highlight just a couple of examples, though, that are from that list of services. These include funding a transitional care clinic in the Wichita area. This focuses on caring for patients who cannot be seen by a primary care provider within 7 days of a hospital discharge. This clinic, which is funded by 340B dollars but open to all patients, including Medicare and Medicaid patients, has reduced unnecessary hospital readmissions and emergency department visits for its patients by 91%. This same team offers a service called the Community Cares Clinic, which is a house call model, and we have nurse practitioners who go and see patients in their home when those patients are physically unable to come in and see a provider in a traditional clinic setting. We also use 340B savings to fund many different medication assistance programs. So when we talk today about 340B savings helping with medication access, we do exactly that. We have charitable care prescriptions for patients who can't afford to pay anything, let alone the 340B price, as well as passing through 340B discounts to our patients. Last year, just those medication assistance programs alone provided over 13,000 prescriptions to 5,000 different patients in Kansas communities and resulted in a savings to patients on prescription medications of over $2 million. As mentioned previously, based on the 340B price calculation, as the price of a given medication increases, the 340B price often drops lower. The end result is meaningful for our patients. Using our 340B prescription assistance program specifically as an example, patients who access this program save an average of over $500 per prescription. However, even with 340B pricing, Ascension Via Christi as an organization still spends over $50 million annually on medications. Additionally, I've heard a lot today about growth of the program. When we calculate 340B savings, it's important to recognize that that number is the difference between the list price of a drug and the 340B price of a drug. So when I hear criticism about growth of the program, I think it's important to recognize that at least part of that growth, and in my experience, a rising 340B savings figure isn't necessarily reflective of additional hospitals, additional pharmacies. It's reflective of rising drug costs generally, is where that difference is coming from. I could go on much longer about how our 340B programs help our patients across Kansas, but as you know, we're largely here today to talk about the challenges that we've seen over the last 2 years from PBMs that have negatively impacted our 340B program and ultimately the patients benefiting from our programs. Beginning in 2020, right as our hospitals were faced with the emerging pandemic, we began to receive notices from drug companies that they would no longer offer 340B pricing at our contract pharmacies. It started with one company, now we have 8, who represent a large number of medications, including all of the manufacturers of all insulin products. This past year, HHS has stated that those actions are unlawful. Each of these companies are in violation of the federal 340B statute, and that issue is working its way through the courts. But while that's occurring, 340B hospitals and our patients are unable to receive discounted prescriptions for medications from these 8 drug companies at our contract pharmacies. When we've had a chance to communicate with some of these companies about why they're doing this, especially right in the middle of the pandemic, after offering 340B prices for more than a decade at these pharmacies, a large part of the response that I've heard, and I'm paraphrasing here, is that we're tired of giving 340B discounts on prescriptions where we're also giving a discount to a PBM. And this, for all of the complications we've heard today, 340B, in my opinion, is not complicated. This is where it gets complicated, though. Because while drug companies are required to offer 340B pricing to 340B covered entities, they also engage in voluntary contracts with PBMs to give discounts on their products to PBMs. So shortly after we started seeing pharmaceutical companies revoke 340B pricing, we also started seeing new actions by PBMs discriminating against 340B providers. In some cases, this includes PBMs offering take it or leave it contracts. Basically you agree to our new terms or else you're not going to be able to provide pharmacy services for our patients. And in other cases, we have had, so backing up a little bit on the first one, so the take it or leave it contracts essentially force us to accept lower reimbursement rates, which the end result of that is kind of dipping into the reduced cost that's intended for 340B covered entities and for our patients. The other thing that we have started seeing from PBMs, either requesting or requiring, with little to no notice, new reporting requirements to offer 340B claims. I think my pharmacist counterparts here did a great job today of explaining what those have looked like. So just to summarize, all of these cases, all of these requests are burdensome. They add unnecessary documentation and paperwork, and they require resources, both financial and personnel, to meet these requests. And in some cases, the requests are just impossible to comply with based on the available technology that we have today. And then kind of lastly here, the concern with these actions themselves, outside of just the overall burdensome and harmful nature to our Kansas 340B hospitals, is the timing of these actions. You asked, earlier about the urgency. We have just come out of the middle of the pandemic here, and now is when both pharmaceutical companies and PBMs have chosen to take these actions against Kansas 340B hospitals, when our hospitals and healthcare providers are focused and stretched now more than they ever have been, I think, to provide quality care to people in our communities. And then secondly, the basis of these actions results from concerns, and I want to slow down here because everything we're hearing about today, the root cause of this is from concerns that both pharmaceutical companies and PBMs have with their own contracts with each other, which they have voluntarily chosen to enter into. Kansas 340B hospitals and pharmacies have no part in these agreements between drug companies and PBMs. We don't benefit in any way from them, but we are being pulled into the middle of a dispute which the companies themselves created. And lastly, I want to clarify an important issue which occasionally comes up, and we've heard it today. When discussing this issue, we'll hear the term duplicate discounts. There is a 340B program rule that prohibits both 340B covered entities and state Medicaid agencies from receiving a discount on the same medication. State Medicaid agencies are entitled to receive a rebate from drug manufacturers, so this rule exists to protect drug companies from paying both a rebate to the state and from a 340B entity having a discount on that same medication. It's important to note, though, that the term duplicate discount when speaking about 340B applies only to Medicaid, not to other payers based on voluntary contracts that drug companies and PBMs may enter into. And so to wrap up today, while we've always known the importance of our Kansas hospitals, I'm sure we can all agree that this past year and a half has just really emphasized that. And so my ask today for this committee is to consider legislation that would protect our Kansas 340B hospitals and our pharmacies within the 340B program from PBM practices which are discriminatory to 340B providers. Both those practices which include PBM contracts to covered entities with our reimbursement based on our 340B status alone. And then secondly, to prohibit practices to implement new reporting requirements that apply only to 340B providers and pharmacies. Thank you for the time you've offered me here today. I really, truly appreciate it. I, as you can tell, probably believe this is a program that's very important to our Kansas hospitals and to the patients that we serve. So thank you.
Thank you. Okay, next up we have Tracy Gilmore from Labette Health. Welcome to committee, Tracy.
Thank you. Good afternoon, Chair Concanon, Vice Chairperson Erickson, and members of the committee. My name is Tracy Gilmore, and I manage the 340B program for Labette Health in Parsons, Kansas. I've been a pharmacist for 26 years, and I've been specifically involved with the 340B program for the last 5 years. My professional experience as a retail pharmacist and my current 340B position enables me to see this program from many different perspectives for the benefit of our hospital and patients. The past 26 years have allowed me to form relationships with local residents, personally and professionally, that I value. In a rural community, the line between patients and friends is very faint. My view of the 340B program does not come from profit margins or policy. My view comes from the community that I serve. I have real grassroots experiences. To address the comment made by Dr. Ha about we have no data that says that this helps patients, I understand the limitations of pharma to be able to pinpoint how it helps patients because they are looking at umbrella data. However, I, as a pharmacist in a rural community, can tell you that it helps patients. One specific instance was just recently. I have a patient that is around 35 years old. His diabetes is out of control. He had an A1C of about 13.5, and my husband, as his eye doctor, we discussed this patient many times, and he was very afraid that he would lose his sight. This patient came into my pharmacy. I also work as within the hospital as a retail pharmacist, in a retail pharmacy that happens to be located in the clinic. This patient came in crying and said because of 340B, for the first time in his life, he was referred to an endocrinologist. He was hoping to get a continuous glucose monitor, and his life will truly be changed. He's missed many days of work because he has not been able to maintain his health, and now he has an opportunity for a long life and to be able to be a productive member of the workforce. I have developed a sense of accountability for these patients. The 340B program is essential to hospitals, other covered entities, and the patients we serve in these communities. Established to allow healthcare providers that serve vulnerable patient populations to access outpatient medications at significantly lower costs in order to stretch scarce resources in their mission to deliver care to all patients, 340B works. Labette Health serves the 6-county area of Labette, Neosho, Montgomery, Wilson, Allen, and Crawford, with a primary location being based in Labette County. Our hospital has 13 registered outpatient locations and 14 contract pharmacies across the service region. These sites have allowed Labette Health to prevent healthcare deserts in areas that would not otherwise have care. In the past 6 years, as hospitals closed in our surrounding regions, Labette Health quickly filled the need for healthcare. When Independence and Oswego and the areas around those cities were suddenly left without health care, Labette Health built an emergency hospital outpatient department, clinics, and express care sites to meet the needs of those communities. Without 340B, Labette Health would not have the resources to be able to fill this need. Labette Health has earned numerous recognitions for excellence in quality and care. However, as a county, we traditionally rank in the bottom 5 out of 105 counties in Kansas for health outcomes. Our patients have a high rate of diabetes and chronic obstructive pulmonary disease and the complications which arise from these conditions. Social determinants of health continue to plague our region. Many of the patients do not have options for travel outside of our region. With the COVID-19 pandemic and the post-care conditions we continue to see, access to quality care is absolutely necessary. At a time when healthcare and other industries alike are facing significant workforce challenges, this critical program keeps patients' chronic healthcare conditions manageable by allowing access to low-cost medications so they can continue to serve in the workforce. 340B is incredibly important for access to care for our hospital, for our local and state workforce and all of the patients that we serve. At this point in the day, you've heard many different perspectives involving the 340B program. As you can see, this program is truly entrenched in the operations of so many not-for-profit entities. Each 340B entity has a familiar yet unique story about the opportunity to help patients brought about by resources of the program. Whether an entity uses 340B to offer discounted medications to patients, to keep the doors of rural healthcare facilities open, to offer additional safety and quality, or to improve community health initiatives, 340B is a program which enables survival. Serving a rural population continues to be challenging as reimbursements decrease and expenses increase. The COVID-19 pandemic has stretched resources to the utmost capacity. Through all of these challenges, the 340B program savings have been vital to our mission of serving patients at a quality level. The past year has provided countless struggles for all Americans. On the front lines of these struggles have been hospitals. Hospitals have had to experience the challenge of navigating the pandemic while simultaneously encountering attack after attack to a program that enables them to survive. After months and months of waging war on two fronts, with the lost 340B benefit and the COVID pandemic surge, the Chief Executive Officer of Labette Health and Army veteran Mr. Brian Williams locked himself in his office on July 2nd to write a heartfelt letter to President Joe Biden. In this letter, he so artfully expressed his concern regarding the attacks on the 340B program, particularly in the midst of the pandemic. With his permission, I have included that letter in your packet along with my written testimony. I've chosen to share the letter from our CEO with you for perspective of what cuts to the 340B program mean in our real world. We could go back and forth for days discussing which players in the program are the good guys and which are the bad actors. Ultimately, it is the people that we all serve that matter. For you, those are your constituents that you represent, and for us, it is our patients that we try to keep healthy. Healthcare workers see the effects on patients up close and personal. Patients in need don't really care about policy or profit. They care about getting health care at a time they need it. Patients care about quality care at a location they can access. As providers, we are concerned with providing them that care. In the last 12 months, attacks on the 340B program have stripped our small rural hospital of over $1.6 million in resources. At a time when all of our resources, both human and financial, should have been centered around fighting the pandemic, we were forced to endure unprecedented attacks to a program we rely upon to meet the needs of our patients. Unfortunately, this will not be the extent of the attacks. It seems as though each month we face a new challenge. Examples have included requiring the submission of sensitive data to third-party vendors, manufacturers refusing to grant 340B pricing to contract pharmacies, a proposed rebate program that would change the entire scope of the program, limited access to medications, discriminatory pricing to 340B covered entities, and other challenges. As we work to compliantly navigate these changes, there are not alternative solutions for us to tap into. We cannot make up for this loss, both the current measured losses and the ones we will not be able to determine for some time. The American healthcare worker and system has endured over 18 months of intense emotional and physical stress. We are losing valuable human resources that I fear that we will not be able to replace in the short run. And many of my colleagues in rural hospitals are concerned about their ability to safely staff our facilities in the future. As situations continued to decline, multi-layered attacks began at the highest level since the inception of the program in 1992. Our rural hospitals were financially vulnerable prior to this pandemic, and without the courageous leadership of state and federal government to support our rural hospitals, many will be faced with the daunting reality of closing their operations. A June 2020 study by Chartis Center for Rural Health found that 1 in 4 rural hospitals were at risk of closing. Should this trend we have seen continue, that would be devastating for Kansans. We need to bring bold and courageous leadership together to stop these actions for the good of our state. Bipartisan leadership is important to prohibit insurers and pharmacy benefit managers from hurting hospitals and outpatient clinics that participate in the 340B program. Not-for-profit entities should not be subject to discriminatory pricing by for-profit insurances and pharmacy benefit managers because they use 340B drugs. Additionally, pharmacy benefit managers in some cases establish barriers to 340B pharmacy participation or to PBM members using 340B pharmacies. And pharmacy benefit managers are threatening the financial security of patients and providers. The Health Resources and Services Administration sympathizes with our concern that discriminatory reimbursement, if left unchecked, will undermine the purpose of the 340B program. 16 states have already passed legislation to protect 340B entities. We've heard a lot of different information from a lot of different players here. And as a federal program, there are many intricacies to this program. However, at a state level, we have two choices. Do we allow 340B discounts to go to for-profit pharmacy benefit managers, or do we let them go to safety net providers and rural hospitals? We ask that the Kansas Legislature follow the lead of many other states to protect the 340B program in Kansas. Kansas constituents ought to have the opportunity to access lower-priced drugs. Your rural hospitals should be able to keep their doors open, and your communities must continue to have a healthy and productive local economy. I appreciate the opportunity to tell our story today. Thank you, Madam Chairperson.
Thank you. Okay, we'll open it up for questions for the hospitals. And Senator Erickson. Oh, yeah.
Thank you, Madam Chair, and thank you. And this is just open to anyone who wants to field it. So the 340B program was implemented in 1992. Prior to that, how were what we would call 340B eligible patients? What did we do then? And how did rural hospitals survive before this?
I am not, I wasn't here in 1992, so I'm not sure. However, I think as healthcare evolves and the challenges continue and the populations increase in their difficulty and scope, healthcare's changed. Things are tougher, and we were given this life-saving program to be able to try to help us in that mission. That's what
I would just add, I was also not a practicing pharmacist in 1992, but from my perspective, I think the program that was implemented was specifically to address drug prices. So from my perspective, I would imagine that prior to that, not that medications couldn't have been costly, but that it was implemented to address what was a problem and what continues to be a growing problem. So I think that, again, to answer your question, not that the problem didn't exist before, but it was implemented to address that exact issue. If that makes sense.
Kind of along that line, I was doing some reading on this topic, and I read somewhere that the children's hospitals or facilities that treat children, that part of the reason why the numbers have expanded so much are because you have to count multiple times. Can you expand on that?
Yeah, I can give you an example at Via Christi. So one of the things that happened, so when I think about growth, one of them I already talked about, is reflective of rising drug prices as a whole. That 340B savings number grows as the drug prices go up. But the other thing, if you look, and again, this is all public information, when we register for a hospital. You have your parent site, which is your hospital that is within your services within the four walls of your hospital. Several years ago, HRSA, to make it more transparent, said anything that's outside the four walls of your hospital that's part of the covered entity, you have to separately register. So in Wichita, for example, both St. Joseph Hospital and St. Francis Hospital are part of the same 340B covered entity, but we have to register each individual nursing unit at St. Joseph. We have another clinic building. It's one building, but we have 10 child sites registered at that address. So to me, it's not reflective. We didn't all of a sudden have more hospitals participating within our organization. It was that we just registered those services in a way that was more transparent, so our registrations look larger, even though it's still the same entity.
That helps to understand, and that happened then nationwide?
We also have that situation. We have a rural health clinic, which is noted as family practice, but after 5 o'clock, it becomes an express care. So from 5 to 8, it treats patients that aren't able to be seen in the day. Because that revenue is separately listed on our Medicare cost report, we have to register those as 2 sites, even though it's one location. So I think that the number has increased, as you say, via transparency. One thing that I didn't mention that I wanted to go back and talk about was we have very strict disproportionate share percentages that we have to maintain, meaning we have to treat a certain percentage of Medicare and Medicaid patients in order to qualify for the 340B program, as well as being not-for-profit. There are very strict guidelines to be into this program. So it's not really a free-for-all, as it has been mentioned. Also, we have very specific compliance, as I mentioned in my written testimony, that we check constantly. So I think that the transparency is, we have HRSA audits, and all of those are public information. So we try very hard to give all that transparency that has been mentioned previously.
Part of the transparency is how the money is used. Do you report that to HRSA?
I'm not involved in the billing or the, that part of the reporting. All of hospitals are very closely audited and, financials especially. So those things are reported, maybe not specifically like down to the line item of what charity care, and that you may be able to expand on this, but they are reported.
Yeah, that's what I would add. We don't report it directly to HRSA. We post it publicly for anyone to see on our website.
Okay, thank you. And then on talking about HRSA, on some issue that we talked about earlier today, there was a comment made that HRSA agreed that that practice should not be allowed, and they discouraged it, but they don't. They're the ones that have oversight. Why aren't they not doing anything about it?
And would this be the PBM issue?
I don't know what the issue is. But
Yeah, there's 2. So I think the one that HHS and HRSA have weighed in very clearly on that they are, from my perspective, actively addressing is the issue of manufacturers revoking 340 pricing at contract pharmacies. I think that is in the process of being addressed at the federal level and through the court system. I think, as you mentioned, there's this separate issue of PBMs discriminating or implementing discriminatory reimbursement or contracts against 340B providers. That's where we heard there's been a bill that's been introduced at the federal level, but not one that has passed yet. And I think that's why we've seen states come in and take action there to stop that practice specifically.
So does HRSA not have any authority to stop any of this themselves?
That's my understanding, is since HRSA doesn't oversee the pharmacy benefit manager industry, that's outside of their realm. There is more the drug side, the drug company side.
I think there is an issue too, and forgive me if I'm wrong, but with state contracting and the federal government, while they have the Protect 340B Act, they are also depending on states because contracting is at the state level, if I'm correct.
Okay, Senator Gossage.
Thank you, Madam Chair. Thank you for being here. So a couple of quick questions. It seems to me that the majority, because somebody said there were 84 hospitals that are in the 340B program. Do we know how many are not in the 340B program?
I do not know that, but I do know that the 84 have strict disproportionate share percentages and treat vulnerable patients and are not-for-profit and have very strict criteria for being in the 340B program.
Great, thank you. Another question is, we had heard earlier about that the acquisition cost is lower for the private patient that comes in with private insurance. How is the acquisition lower, and from whom do you acquire this acquisition to where you get the lower price?
The acquisition price is the 340B price based on the average manufacturer price that's calculated quarterly. And again, I believe Sarah mentioned that there's a statutory discount, and then anything greater than that comes from when manufacturers increase the cost to the patient, to all patients, at a rate higher than inflation.
Thank you. And I just want to say that thank you, everybody, for being here today. Kind of my takeaways, some of you know that I've been in the health insurance world now for 18 years, and this 340B medications is only a small part of this regulation, and I had no idea. I thought that was the full regulation. So that was interesting. Another thing is contracting pharmacies prior to 2010. We heard we're about 2,300, and now we're over 109,000 contracting pharmacies. And that's interesting to me. And finally, we heard $38 billion now have been given out to various contracting pharmacies in the form and entities in the form of dollars from the pharmaceutical companies. And I don't think that was the original intent. So all of this has been very enlightening, and I thank you all so much for being here. And the last thing I will say that I learned is reimbursement for the 340B eligible patients, as I understood it, is the same reimbursement, the same acquisition price, no matter whether it's a private individual with private insurance or it's a 340B eligible patient. Thank you so much. Thank you, Madam Chair.
Further questions? Representative Miller.
I think it was Ms. Haw earlier that cited some study or survey. I think she said it was through Congress that indicated 50% of the money was not going to the people it was intended to. Do you ladies, did you hear that? Do you have a response?
I do, and I think that I'm not familiar with the study itself, but where I can see that coming from, if I were answering on behalf of an organization that participates in 340B, in some cases it makes perfect sense to pass the discount through to a patient. There are some 340B prices where you go from a patient potentially paying hundreds of dollars if they're uninsured to $10 or $20. That's very reasonable, right? In other cases, though, we have medications that are $10,000, $20,000. If you get a 25% discount on that, wonderful, I can pass through and you can still pay $10,000 for that medication. So the idea is that, yes, sometimes we pass through that discount. Sometimes it doesn't make sense to do that, but we still have that source of savings that goes to fund all of the services that you've heard us talk about today. So if we go back to the true intent of the 340B program, it isn't necessarily to 100% of the time pass a discount straight through to the patient. It's to stretch scarce federal resources to reach patients, and that can be done in a variety of ways.
Other questions? Okay. I think you wore us out. Thank you, ladies. Okay. So we've heard from all the conferees that we're going to hear from today. I kind of wanted to, like I said earlier today, lay this out with an overview of what the program was all about, and then talk more about how it's impacting Kansas and each of the specific stakeholders. My thoughts are that I wanted to keep this pretty narrow to talk about the legislation that is currently alive in the legislature now, which has to do with discriminatory contracts. I knew some other things would probably come up, and I think that it's important for us all to know what the whole 340 program is. It's not for us to decide whether it's a good program or whether it's running just right, or any of the other things that have come up today. That it's the law, it's the federal law, and we're not changing that. But what we do have a right to do is to address the discriminatory contracts. So kind of with that in mind, what else, or even some of the other things, if you want to hear more about them, what are we missing? What else do you need to, who do you need to hear from? Representative Wolfmore.
Well, I think one thing I would like to hear about, I mean, I am just, been looking over this list of the 16 states, as several other have noted, and it's just amazing to me that the legislation they passed has been, in some cases, unanimous or nearly unanimous. So obviously, they're doing something in this state, in these states, that has broad appeal and that it works. So I would love to hear, especially about Arkansas, since that one was referenced, but I'd love to hear a little more about what they've done. Thank you.
So we have a couple of different charts of what kind of legislation, but you'd like to have more detail of what they've done?
I would.
Okay.
Thank you.
Okay. Senator Ware.
Well, it's already been stated, Vic suggested we really need to hear from the PBMs.
Thank you. That was already on my list.
And actually, Madam, there is written testimony I found.
Oh, yeah, they did submit that ahead of time. Thank you for pointing that out. Any other discussion? Representative Miller.
I don't know that we need a hearing, but I would like at our next meeting for research to at least brief us on these two bills that were referenced as currently residing in committee. And if there are others that relate to the issue as well, I'd like to know what we already have in front of us, but we might not need to reinvent the wheel.
Thank you. Yeah, we had actually considered doing that today, but didn't want to put the cart before the horse. Anything else? Okay, thank you for sticking it out. This is a tough subject to sit and listen to and talk about for a whole day. I mean, I've been talking about it quite a bit lately, and I want to thank Megan. Thank you. She's been great to help on this. All right, we will adjourn and see you on December 9th.